Good morning, and welcome to Clinical Trials Plenary Session 3, titled Immunotherapy Combinations, the New Frontier in Lung Cancer. My name is Alice Shaw. I'm Director of Thoracic Oncology at Mass General Hospital, and it is my honor to chair this plenary session. I was fortunate to co-chair the AACR Clinical Trials Committee this year with Dr. Lou Weiner, and to witness over the last several months some truly incredible progress that is being made across all of oncology. Today we will hear not one or two, but 5 phenomenal presentations, all of which highlight how rapidly basic immunologic advances are transforming the clinical care of patients with lung cancer. These studies are groundbreaking and in some cases practice-changing. 3 of the 5 studies are being published today simultaneous with their presentations in the New England Journal of Medicine, a true testament to their profound importance to the field. Today, we will be live streaming the session in order to share these exciting results with as many as possible. Please note that due to the live streaming and this venue, as well as the very tight schedule, we will not be taking questions after each presentation. So with that, I'd like to invite our first presenter to the stage, Dr. Lina Gandhi from NYU Langone in New York.
Thank you for the opportunity to present Keynote 189 on behalf of my co-authors. This is a randomized, double-blind, phase 3 study of pembrolizumab or placebo in combination with pemetrexed and platinum as first-line therapy for metastatic non-small cell lung cancer. These are my disclosures. In principle, there's many reasons that chemotherapy may be synergistic with immunotherapy, but in reality, chemotherapy and different types of chemotherapy can have complex and pleiotropic effects on anti-tumor immune responses. There certainly are immunogenicity promoting factors that can happen from a variety of agents, including upregulation of MHC1, enhanced dendritic cell activation, alterations of T effector cell function, proliferation, recruitment, activation of innate immunity factors, and favorable effects on the immune microenvironment in terms of decreasing Tregs, MDSCs, but there can also be increases in MDSCs and decreased T effector cell function depending on the context, the timing. So at least we know that in the context of these pro-immunogenic functions, anti-PD-1 therapy could have the potential to enhance those positive effects and reduce the negative effects of chemotherapy. Pemetrexed in particular is a drug which has been shown to increase CD8 cell recruitment into tumors, increase gene activation associated with T effector cell function and T cell activation. This was presented at World Lung Cancer last year, and an updated poster is to be presented at this meeting tomorrow. And that may be one of the factors in this combination to be evaluated. Other tumor models have looked also at the combination of platinum and pemetrexed and shown some synergistic effects in preclinical models. Clinically, pembrolizumab, a humanized IgG4 monoclonal antibody against PD-1, has already been approved as monotherapy in the previously treated non-small cell lung cancer setting for patients with PD-L1 expression of greater than or equal to 1%, and as monotherapy in the first-line setting for patients who have 50% or greater PD-L1 expression. A phase 2 open-label randomized study was conducted with this combination of platinum, pemetrexed, and pembrolizumab, which already demonstrated an increased response rate and PFS, and actually resulted in approval of this regimen in the US and several other countries. But the study we're talking about today is a global, randomized, placebo-controlled, blinded study conducted in 16 countries at 126 different sites. The study enrolled stage 4 non-squamous cell lung cancer patients without EGFR ALK alterations who had a good performance status and were able to provide an archival tissue sample for PD-L1 testing prior to enrollment. Although symptomatic brain metastases were not allowed on study, patients with asymptomatic brain metastases up to 1.5 centimeter were allowed on study. Patients were not allowed to have had a history of pneumonitis requiring steroids. Patients were stratified on the basis of these factors shown here and randomized 2-to-1 to receive either pembrolizumab in combination with platinum pemetrexed or placebo. in combination with platinum and pemetrexed. And after 4 cycles of the platinum doublet, patients went on to receive either pembrolizumab, pemetrexed maintenance, or pemetrexed plus placebo maintenance. The control arm patients were allowed to cross over to pembrolizumab monotherapy at any point if blinded independent central review confirmed progression and they were eligible to receive pembrolizumab. There were 2 primary endpoints of the study. There were co-primary endpoints of overall survival and progression-free survival. Secondarily, we also looked at response rate, duration of response, and safety. And the effect of PD-L1 expression on efficacy was also evaluated in an exploratory manner. The intention to treat population was the primary analysis population for efficacy, and all patients who received greater than or 1 dose of medication were evaluated for safety. Statistical considerations were based on a planned enrollment of 570 patients. The actual enrollment was 616. The overall alpha for the study was strictly controlled at a one-sided alpha of 2.5%, such that the study had 90% power to show an HR for PFS or OS at 0.7 at these alpha levels. There were 3 planned analyses. This is the first interim analysis, which was planned to occur after the enrollment was complete and approximately 370 PFS events were observed. The data cutoff for this presentation is November 8th, 2017, and the median follow-up 10.5 months. The actual observed number of events was 410 for PFS, and you can see with these alpha levels of this analysis that there was a very stringent bar to declare success at this early interim analysis. 616 patients were randomly allocated, and ultimately 405 treated in the combination arm, 202 in the control arm. To date, close to 34% of patients are still on treatment in the combination arm as compared to close to 18% in the control arm. Most patients discontinued for radiographic progression and other reasons as are listed here. The patients in the control arm, about 67% of them crossed over in study to receive pembrolizumab, and an additional 18 outside of study received their first subsequent therapy as immunotherapy, for a total effective crossover rate to immunotherapy of 41% of the intention to treat population, or 50% of those, excluding those that are still on therapy. In the combination arm, 30.5% of the intention to treat population, or 45.8% of those, excluding those still on therapy, went on to receive at least 1 subsequent therapy. These are the baseline characteristics of the patients, and you can see that they're mostly equally matched, with the exception of there are a few more men in the combination arm. There was a higher percentage of patients with ECOG PS of 1 and who had prior thoracic radiation in the control arm. Overall, there were 17 to 18% of patients who had stable brain metastases, and a third of these overall were untreated brain metastases. This is the frequency of PD-L1 subcategories in each arm of the study. You can see that they're well matched. There's not a disproportionate number of patients who had a different level of PD-L1 expression. Approximately a third are represented in the less than 1% category, 1 to 49%, and greater than or equal to 50%. This is the overall survival Kaplan-Meier analysis of the 2 curves. You can see that there's a clear difference between pembrolizumab, pemetrexed, and platinum versus the control arm. Overall, the hazard ratio for death was 0.49 with a p-value of less than 0.00001. Apparently there are 7 zeros in that number, but that's too hard to say. The median survival in the control arm was 11.3 months. The median overall survival for the pembrolizumab combination arm has not yet been reached, but a landmark analysis done at 12 months estimates 69.2% to be alive at 12 months in the combination arm versus 49.4% in the control arm. In all subgroups evaluated, this survival benefit was maintained. That includes patients who are non-smokers, although that was a small proportion, and it includes all levels of PD-L1 expression, including those with less than 1% PD-L1. And it includes those with baseline brain metastases. These are the survival curves broken out by PD-L1 expression, where you can see that even though there is a higher difference in the highest level of PD-L1 expression with a hazard ratio of 0.42, there's still a hazard ratio of 0.59 for those with less than 1% PD-L1 expression. These are the progression-free survival Kaplan-Meier curves, again showing a clear difference with early separation of the curves that is maintained and continues to separate. Hazard ratio of 0.52, the p-value of less than 0.00001. The median overall survival in the control arm was 4.9 months as compared to 8.8 months with the combination. And at a landmark analysis of 12 months, 34% of the patients in the pembrolizumab combination arm are estimated to be progression-free and alive, compared to 17.3% of those in the control arm. In all key subgroups, again, there was a benefit, although the patients who are over 65 and for those who have less than 1%, the confidence intervals just cross 1, but they all lie to the left of this line. These are the progression-free survival curves broken out by PD-L1 TPS score, and again you can see that with increasing levels of PD-L1 expression there is a greater degree of benefit, with a hazard ratio of 0.36 for those with the highest levels of expression, but still a hazard ratio of 0.75 for those with the lowest levels of expression. The response rate was also better in the combination arm at 47.6% compared to 18.9%. Only 8.8% of those in the combination arm had a best response of progressive disease compared to 17.5% of those in the control arm. The median duration of response was 11.2 months compared to 7.8 months in the control arm. These are the response rates broken out by PD-L1 subcategory, and you can see that there's a difference between control at all levels of PD-L1 expression, with a marked 61.4% response rate in those with the highest levels of PD-L1 expression. Overall, patients in the combination arm had a longer treatment duration and exposure to treatment, mean of 7.4 months versus 5.4 months. More patients in the combination arm completed 4 cycles of platinum, completed more than 5 cycles of pemetrexed. These are the adverse events in the study, overall adverse events, and you can see that they're fairly similar between both arms. Overall, similar grade 3 to 5 adverse events in both arms, those that led to death in both arms. There was a higher rate of discontinuation of all treatment with adverse events, due to adverse events in the combination arm, 13.8% compared with 7.9%. Notably, the immune-mediated side effects, or those attributed, to immune effects, are predominant in the combination arm, but the overall rate of grade 3 to 5 events, or those that led to death, is really no different than monotherapy. These are the overall frequency of the overall all-cause adverse events with a greater than 20% frequency, and you can see that in both arms they're relatively similar. There's a slightly higher rate of nausea, diarrhea, and rash, as well as grade 3 to 5 neutropenia in the combination arm, but when these are adjusted for dose exposure, these differences go away with the exception of febrile neutropenia. The immune-mediated adverse events, as expected, are predominated in the combination arm, but again, the overall frequency of most of these approximates that of monotherapy. Although there was a higher grade 3 to 5 pneumonitis than in the control arm, the overall rate is still less than 5% in this study, even with combination. Nephritis at a rate of 1.7% was the exception that was higher than seen in monotherapy, which is typically around 0.4%. And renal events are the perhaps outlier in this study, that there was a higher frequency of acute kidney injury in the combination arm compared to the control arm. Each of the drugs in this combination, pembrolizumab, pemetrexed, and platinum, can all have renal toxicity independently, so that may have been part of this. The grade 3 to 5 frequency was 2% versus 0%, with 2 deaths occurring in the combination arm. Most of these events did occur in the setting of acute illness, concurrent multiple other toxicities, and were likely multifactorial. Nephritis, which did have some overlap with acute kidney injury, had a 1.7% frequency, 1.5% grade 3 to 5. It's hard to know for sure how many of these renal events were immune-mediated or inflammatory in nature, because most patients did not get a renal biopsy. In summary, pembrolizumab combined with pemetrexed and platinum provided superior overall survival compared with placebo and pemetrexed and platinum, with a hazard ratio of 0.49. This benefit was observed irrespective of PD-L1 tumor proportion score. The PFS and ORR were also superior, with a durable response, more durable responses seen. And the AE frequency and severity was overall similar between the two arms. Pembrolizumab did not appear to clearly increase chemotherapy toxicity, and vice versa, pemetrexed and platinum did not appear to exacerbate pembrolizumab-associated AEs, with the possible exception of renal toxicity. In conclusion, Adding pembrolizumab to pemetrexed and platinum induction therapy with pemetrexed maintenance therapy significantly improved overall survival, progression-free survival, and overall response rate in patients with untreated metastatic non-squamous non-small cell lung cancer who do not carry EGFR alterations. Overall, pembrolizumab with pemetrexed and platinum has a manageable safety profile, and this may represent a new standard of care for first-line treatment of metastatic non-squamous non-small cell lung cancer, irrespective of PD-L1 expression. These results are also published today in the New England Journal, where you can get more detail. I would like to acknowledge the patients, their families, and their caregivers who participated and are still participating in this study, and the investigators and site personnel from all 126 sites in 16 countries. We would like to thank Eli Lilly and Company for providing pemetrexed and additional personnel at Merck, including Roger Dancy and Greg Lubinecki, and Yue Shen Tu for statistical expertise. Thank you.
Thank you, Dr. Gandhi, for presenting this very exciting abstract. To discuss this, I'd like to invite Dr. Roy Herbst from Yale Cancer Center to the podium.
Go ahead. Thank you, Dr. Shaw and the committee, for the opportunity to discuss Keynote 189. I've entitled my discussion, "Can You Hear the Music?" My disclosures. Well, we really have a new era for non-small cell lung cancer treatment. It's incredible what's happened over the last 20 years. Chemotherapy, of course, came first, anti-angiogenic therapy, and then the genomic revolution, leading to targeted therapies galore. But in recent years, it's been immunotherapy. And now we have Keynote 189 for untreated non-squamous non-small cell lung cancer. So the question I'm going to address now, is this trial the keynote, or will we need to wait for an encore? What I'm going to discuss today is first a little bit of background about lung cancer, as this was the first talk of the morning, analysis of the efficacy and safety results, the role of PD-L1 and other biomarkers going forward, and then lastly conclude with how these data will change the standard of care and what are the next steps. What about standard of care? Well, lung cancer is the leading cause of death worldwide. You can see the number of cases worldwide, 1.8 million cases with 1.6 million deaths. 85% of lung cancer is non-small cell lung cancer, and non-squamous cancer is the largest proportion of those. And PD-L1 status is shown on the slide. Now, the current treatment is broken down for non-small cell lung cancer by squamous and non-squamous. And on this slide from a recent review in JAMA Oncology, you can see that in the frontline setting, the combination we're talking about today is already approved. If a patient has high tumor proportion score, greater than 50%, they can already get pembrolizumab or the pembrolizumab chemotherapy combination, and they can also get it if they have less than 50%. However, it hasn't been used as much as it could be because the trial that was based on was small, and everyone was waiting for the results that we heard today. Now, what's the rationale for combination therapy? You heard that very eloquently from Dr. Gandhi. I won't belabor the point, but certainly you could be increasing antigen presentation, decreasing some of the regulatory cells. So certainly we're seeing now with this study and the one that's going to come after it, that chemotherapy does seem to have at least an additive effect, or at least an independent effect. But one thing that I just want to point out is there are theoretical concerns regarding the side effects of cytotoxic chemotherapy on the proliferation of T cells. It might differ depending on which chemotherapy you use, how much, and I think we have to wait for long-term data to truly understand the combinatorial effect. Are we having an effect on T effector cells? It appears not, but what about on some of the memory and other T cells that are being produced? Well, here's the data that led to the trial that we heard about today, the Keynote 21. This trial was actually quite positive. You can see the PFS, 13 months for the treatment group, 8.9 months for the control. This has been updated, and survival was trending, but it was only 123 patients. So many said, we need to see more. It was FDA approved, but what about a more substantial, larger trial, as we heard about today? So that's the background for today. So the next, what about the efficacy and safety results from today's study? Well, you already heard the trial from Dr. Gandhi, 616 patients, a robust trial. Remember, it's only non-squamous, non-small cell lung cancer. Also, EGFR and ALK alterations were excluded. So we're not going to be able to ask any questions about those alterations from this trial. No symptomatic brain metastases were allowed in this trial, though patients were allowed on if they'd been treated. And PD-L1 expression was not used to go on the trial, but it was obtained, and you can see that it was stratified as shown. Well, here are the results, and quite frankly, they exceeded expectations. You can see that it met all the primary endpoints. The hazard ratio, as you can see, for overall survival in the general population of 0.549 is quite extraordinary. I sat on the Meaningful Outcomes panel for ASCO several years ago, and we said that 0.7 or 0.75 would be considered a major advance. This truly is a good number. You can see the PFS also significant at 0.52, and you can see the response rate also improved. And all the exploratory endpoints were positive in this trial, except perhaps for PD-L1 less than 1% PFS, which I'll show you. The adverse events we just heard about from Dr. Gandhi. There were a few more additional events in the patients who got the combination, but the grade 3-5 events were pretty much the same. A few more patients who discontinued treatment. And then we heard about the renal toxicity. It looks like that was mostly low grade, but it is something to look on in the future, especially if these patients are going to go on to receive other therapies. Now, what about PD-L1 and its role? So much work has gone into developing PD-L1. It's actually sort of ironic because pembrolizumab was developed using PD-L1 as an assay. And of course, this slide, which I received from Fred Hirsch, from the ISLAC, the Lung Cancer Society Harmonization panel, looking at different PD-L1 assays, really has set the standard for using PD-L1. And in fact, I can tell you at our center at Yale, we can usually get this result before we see the patient. And actually, if you look, PD-L1 status is obtained in a large number of patients with lung cancer as we sit here today. In fact, it sort of correlates the increase in PD-L1 testing with the approvals of pembrolizumab, first in the second line, and then, of course, in October of 2016 in the front line. And you can see about 80% of patients are being tested for PD-L1. But what are we going to do now? Here we have a trial that has this result, but no PD-L1 status is required to receive the therapy. Well, we have to look at the exploratory analysis, and I show this here. Up top by PD-L1 status is the response rate. On the left is the overall survival, and on the right is the progression-free survival. And I'll go through them by three groups. Well, first, the group that has the 50% PD-L1 status, the high group. You can see this group has the best numbers and hazard ratios for PFS, OS, and for response. All quite good. In the middle range, the same thing. Positive for survival, positive for PFS, and a response rate considerably better. The same is true for the low group, the less than 1%, with one small exception. The curves are touching, and it looks like it's not quite significant at the PFS for the TPS less than 1%. Now, that is cause for a little bit of concern. It tells you that the biomarker is somewhat predictive, but there's still a positive survival number. And quite frankly, in lung cancer, survival trumps all. So this is something to keep in mind as we move forward, but I don't think it's a major limitation of the study. Now, of course, everyone's wondering, what are we going to do now? We already use pembrolizumab in the patients that have PD-L1 staining greater than 50%. How do we bring Keynote 189 into those patients? So what I did is I've compared the Keynote 189, just the 50% PD-L1 group, with Keynote 24, which of course were all patients with PD-L1 status 50%. So you can see those curves here, back to back, and let me point out a few things. The question is, what marker do you use to compare the studies? Well, if you just look at a landmark of 1 year, which is perhaps, in my opinion, the most reasonable given the follow-up from this study, you can see the Keynote 24 was 70.3% survival at 1 year. And with this study, we have 73%. So at 1 year, they're pretty comparable. But there are differences. You can see the response rate for Keynote 189 in this population was over 61%. and the response rate in the Keynote 24 was 44.8%. So there is a higher response rate, and the hazard ratios are better as well. Now, one thing about Keynote 24 is there's now 2-year numbers on this study, 51% 2-year survival with a median of 30 months. We don't yet have that for Keynote 189. So numerically higher for 189, but still early. So I've shown you the data. I've made a few points about PD-L1. Now for the conclusions. Will these data change the standard of care? So here's the metronome. My time is up. And the answer is Pembro, Pem, Platinum a new standard of care for untreated non-squamous non-small cell lung cancer? And the answer is an absolute yes. This is a randomized phase 3 trial, positive for all primary endpoints, that sets a new standard for first-line metastatic non-squamous non-small cell lung cancer. Survival benefit is seen across all subgroups, and treatment was well tolerated with only slightly increased adverse events. Question 2, should the PD-L1 biomarker assay still be used for patient selection? And the answer to that, I believe, is also a yes. The response rate, the PFS and OS appear to track with PD-L1 status, which remains important. Other biomarkers should also be explored, perhaps TMB, which we'll hear about later this morning. Despite the remarkable results, and I believe they really truly are, let's keep in mind that only 34% of patients remain progression-free at 1 year. I say that at this AACR meeting because we have to continue the science. There are many patients who still don't respond, so we have to continue to look for newer things. And longer-term follow-up likely will be needed to fully understand the effects of combination chemoimmunotherapy. Now this slide, which is from a recent Nature review, I thought I could use to sort of give my thoughts as to how I'll use this in my clinical practice. So for patients who have oncogene-addicted tumors, in those patients, based on these data, further research is needed on the impact of checkpoint inhibitors on these tumors. Although perhaps we'll hear something in the next few talks about a different chemo combination. For those patients who have PD-L1 that's between 0 and 50%, I think it's quite clear. These patients, based on these data, non-squamous patients, which are a lot of patients, should receive chemotherapy plus pembrolizumab. But what about the 50% group? That's going to take a little bit of discussion, and it's going to happen on Michigan Avenue probably later today. But in this setting, you can do either. Patients now have the option of pembrolizumab alone or chemotherapy plus pembrolizumab, depending on the clinical circumstances, toxicity concerns. You can imagine someone who has a large, bulky tumor needing that higher response rate. You might use the combination. You might imagine someone more frail where you won't. And it's really a discussion between the patient and the physician. So we also need another trial. So if there is an encore, perhaps this is it. So isn't it nice that over a year now, the SWOG and the ECOG-ACRIN have been working on this trial that is moving forward, that's going to take the arm of this trial, shown here, and compare it to pembrolizumab, followed by either carboplatin pemetrexed or continuing the pembrolizumab, followed and adding in chemotherapy. And trials like this are what we need. We now need use trials to figure out how to bring this into practice with biomarker results. And actually, just last Monday, we learned that the 1% PD-L1 trial with pembrolizumab was positive, and that makes this trial the perfect trial because you can take all patients PD-L1 positive and ask this question. It'll be some years before we have this, but let's push to put people on the clinical trials, and on the clinical trials for the NCTN. That's why we have them, and that's why we're working collaboratively, which is, again, a theme of the AACR meeting. Finally, let's not forget biomarkers. We're going to hear about those in the next talks, whether it be sequencing, whether it be gene signatures, whether it be immune profiling, TMB, imaging. Biomarkers are going to be important. We're doing well. We can do even better if we personalize this therapy. And then, of course, let's not forget combinations. Combinations are going to be key. Resistance will develop. Patients will not respond. And combinations based on biomarkers are important. So to summarize, what's next? This regimen should be moved to earlier stage disease. Adjuvant therapy, neoadjuvant therapy. Use your best therapies early on in lung cancer. Always been something we've done. Explore activity in squamous carcinoma, trials pending. Small cell cancer, oncogene-driven tumors. Combine with anti-angiogenic agents. Biomarkers in science to better determine mechanisms of sensitivity and resistance. And then, of course, develop new combinations. We're moving towards personalized immunotherapy. This will be a backdown for that, and we need to look at that in the future. Thank you very much.
Thank you, Dr. Herbst, for that outstanding discussion. I'd now like to welcome to the stage Dr. Mark Szynski from Florida Hospital Cancer Institute, who will be speaking on Empower 150, efficacy of atezolizumab plus bevacizumab in chemotherapy in first-line metastatic non-squamous non-small cell lung cancer across key subgroups.
Colleagues, on behalf of my co-authors, co-investigators, and fellow members of the steering committee, it's my pleasure and honor to present Empower 150, efficacy of atezolizumab plus bevacizumab and chemotherapy in the first-line treatment of metastatic non-squamous non-small cell lung cancer across key subgroups. These are my disclosures. Standard of care for patients with advanced first-line non-small cell lung cancer include targeted therapies for those patients with oncogenic drivers. Best examples are EGFR mutation or ALK rearrangement. Pembrolizumab in those patients with high PD-L1 expressing tumors, greater than 50%. And platinum-based chemotherapy with or without bevacizumab or with or without pembrolizumab. Atezolizumab is an anti-PD-L1 antibody that blocks the binding of PD-L1 to its receptors PD-1 and B7-1, thus restoring tumor-specific immunity. Atezolizumab has demonstrated overall survival benefit and is approved in the US, in Europe, for the treatment of non-small cell lung cancer in the second-line setting and beyond, regardless of PD-L1 expression. Phase 1b data of atezolizumab plus platinum-based doublet chemotherapy in patients in the first-line setting of non-small cell has demonstrated promising efficacy and tolerable safety in small studies. This slide summarizes the rationale for combining atezolizumab with bevacizumab in chemotherapy. In the lower left, tumor cell killing by chemotherapy may expose the immune system to high levels of cancer cell antigens. Inhibition of VEGF can promote T cell priming and activation via dendritic cell maturation. Normalization of the tumor microvasculature through VEGF inhibition increases T cell tumor infiltration. And VEGF blockade can establish an immune-permissive tumor microenvironment by decreasing myeloid-derived suppressor cells in regulatory T cell populations. All of these facts suggest that atezolizumab's T cell-mediated tumor cell killing can be enhanced through bevacizumab's reversal of VEGF-mediated immunosuppression. This is the design of Empower 150. Stage 4, or recurrent metastatic non-squamous non-small cell lung cancer patients were included, including patients with EGFR and ALK aberrations. These patients were chemotherapy naive, had to have tissue available for biomarker testing. Any PD-L1 IHC status was accepted onto this trial. The stratification factors included sex, PD-L1 IHC expression prospectively by SP142, and the presence or absence of liver metastasis. The control arm is arm C, standard carboplatin, paclitaxel, bevacizumab for 4 to 6 cycles, followed by bevacizumab maintenance. Arm B grafted atezolizumab onto the components of the control arm for 4 to 6 cycles, and followed by atezolizumab and bevacizumab maintenance. Arm A substituted atezolizumab for bevacizumab with the carboplatin paclitaxel for 4 to 6 cycles and continued atezolizumab as maintenance therapy. Patients were treated in the maintenance setting until disease progression or loss of clinical benefit. The primary PFS analysis of Empower 150 assessed whether the addition of atezolizumab to arm C, so the combination of carboplatin, paclitaxel, and bevacizumab, provided clinical benefit. This analysis will focus on whether this combination provides clinical benefit in key biomarker and special interest subgroups. The biomarkers in this trial provided an opportunity to evaluate multiple strategies to enrich for PFS, including the T effector gene signature and PD-L1 IHC status, both by SP142 prospectively and SP263 retrospectively. The T effector gene signature, defined by messenger RNA expression of the 3 genes listed in the second bullet, is a surrogate both for PD-L1 expression and pre-existing immunity. In the prior phase 3 OAK study, the T effector gene signature expression appeared to be a more sensitive biomarker of PFS benefit for atezolizumab monotherapy versus docetaxel than did PD-L1 IHC expression. Patients on this trial were also screened either locally or centrally for EGFR mutations or ALK rearrangements. I was doing great till the slides won't advance. Here is the summary of the study populations and objectives. The intent to treat population included all randomized patients. The intent to treat wild type population, which was 87% of the patients, refers to the patients without EGFR or ALK genetic alterations. The EGFR ALK positive subgroup comprised 13% of the patients on this trial. Furthermore, the intent to treat wild type population was segmented into the T effector high wild type or the T effector low wild type. The co-primary objectives were investigator-assessed PFS in the intent to treat wild type and T effector high wild type subgroups, as well as overall survival in the intent to treat wild type. Key secondary objectives were investigator-assessed PFS and OS in the intent to treat, as well as the PD-L1 IHC subgroups and the other endpoints listed on the slide. This trial in November 2017 was positive for PFS, comparing arm B versus C in the intent to treat wild type population and the T effector high wild type population, and this data was presented at ESMO IO in December in Geneva. Last month in March, the trial met its endpoint for positive overall survival, and this overall survival data will be presented at an upcoming meeting. The overall survival boundary for Arm A versus Arm C has not been crossed. Results for Arm A versus Arm C will be reported at the time of final overall analysis. This is the PFS benefit in Arm B versus Arm C in the intent to treat wild type. The difference in median survival for Arm C was 6.8 months versus 8.3 months on Arm B, the atezolizumab containing arm. Hazard ratio was 0.62. When one looks at the landmark PFS at 1 year, it was 18% on Arm C and doubled to approximately 37% on Arm B. Again, as I mentioned, OS positivity has been reached and will be presented at an upcoming meeting. The analysis of this presentation is to help further understand the PFS efficacy of atezolizumab plus Bev and chemotherapy in key patient populations in this study. These include PD-L1 IHC expression subgroups defined by SP142 and SP263, patients with EGFR and ALK genetic alterations, and patients with liver mets at baseline. Due to tissue availability, the biomarker evaluable population for the SP263 analysis included 503 patients versus the 692 intent to treat wild type population. You can see in looking at the PFS that the benefit was similar, with identical hazard ratios at 0.62 and nearly identical point estimates of median PFS on both arms of the study. This is a forest plot that looks at PFS benefit across all biomarker subgroups. I'll draw your attention to the bottom, which is the intent to treat wild type hazard ratio of 0.62. You can see PD-L1 categorized into high, low, or negative, and you can see the impact of Arm B was greatest in the high expressors, but even in the low expressors was significant at 0.77. Listed in the top section of this forest plot are the two subgroups, the T effector high and T effector low. And you can see that for the T effector high, 0.51 hazard ratio for PFS, and the T effector low, 0.76, very similar to the PD-L1 negative. And even though the T effector gene signature enriches for PFS, it's very similar to the information gained in the PD-L1 IHC subset. Now, the blueprint analysis showed that the SP142 assay differed analytically from the other PD-L1 IHC assays, SP263, 22C3, and 28.8. In that analysis, SP263 and 22C3 were similar and highly concordant. A prior report looking at the SP142 assay was shown to be clinically equivalent with regard to outcomes compared to the 22C3 assay in the OAK trial, and this was presented at ESMO last year. You can see here the PD-L1 prevalence in IMpower 150 using both SP142 shown to the left and SP263 shown to the right was similar with substantial overlap observed. 76% of patients stained for both antibodies and 13 to 14% of the population stained with only one of the antibodies. 47% of the patients in both assays were negative, and you can see the proportion in the low and high groups was roughly the same. I'll show you three Kaplan-Meier curves. The first one is looking at PFS for arm B versus C in the SP142 to the left and the SP263 to the right. You see the hazard ratio 0.49 and 0.50 respectively is identical. In the PD-L1 low subgroup to the left SP142, the hazard ratio is 0.53. For SP142 and 0.57 for SP263. And then in the PD-L1 negative subgroup, a hazard ratio of 0.77 to the left for SP142 and a hazard ratio of 0.72 for SP263. Turning now to the other key populations. This includes the EGFR and ALK population, as well as the liver metastasis population. You see here the intent to treat, which included the EGFR and ALK, had a hazard ratio for PFS in favor of arm B of 0.61. When one looks at the EGFR ALK only as a group, the hazard ratio was slightly better at 0.59. ALK rearrangement population, 0.65. EGFR mutation population at 0.60, dividing the two common sensitivity mutations, exon 19 deletion or L858R exon 21, you see a hazard ratio of 0.41. With regard to liver metastasis, a negative prognostic factor, no liver metastasis, a hazard ratio similar to the intent to treat population, presence of liver metastases with a hazard ratio for PFS in favor of arm B of 0.4. This is the PFS for arm B versus C in the EGFR ALK positive patients. You see a hazard ratio of 0.59. The median PFS for arm C was 6.1 months, and for arm B, 9.7 months. This is a population where anti-PD-L1 or PD-1 monotherapy in the second plus line setting has not shown significant benefit. When one looks simply at the two sensitivity mutations, exon 19 and L858R, you see here the hazard ratio is 0.41 as we showed in the forest plot, and the median PFS for arm C was 6.1 months compared to 10.2 months for arm B. In an attempt to analyze PD-L1 expression and how that may have affected the outcomes that I just showed you, this slide is a bit of a busy slide. The arm B is shown in blue. In the red pink is the arm C, so the control arm. The darker colors are the intent to treat wild type population, and the lighter colors represent the EGFR ALK positive population. And you can see here that this benefit seen in this group can't really be explained because there seemed to be lower PD-L1 expression in general in this group of patients. This is the PFS curve comparing arm B to arm C in patients with liver metastases at baseline. You see a hazard ratio of 0.40. a median survival for a median PFS for arm C at 5.4 months and for arm B at 8.2 months. Obviously, we know this is a negative prognostic factor in advanced non-small cell lung cancer. Again, in a similar analysis, looking at PD-L1 expression, the same lower expression seemed to be true in this population, similar to the EGFR ALK population. So in summary, the atezolizumab plus bevacizumab plus chemotherapy demonstrated significant PFS benefit in chemotherapy-naive, non-squamous, non-small cell lung cancer group across all PD-L1 subgroups, and regardless of the IHC assay that was used. Clinically meaningful PFS benefit was observed in all patients, including those with EGFR mutations, ALK genomic rearrangements, and liver metastasis. Anti-PD-L1 or PD-1 monotherapy has not shown significant benefit in the second-line plus setting in this EGFR ALK genetic alteration population. Tumors in patients with liver metastases are characterized by immune-suppressive tumor microenvironments and generally demonstrate poorer outcomes. The observed efficacy in these key subgroups may be due to the addition of bevacizumab to atezolizumab. These data suggest that this combination of atezolizumab plus bevacizumab plus chemotherapy provides a new treatment option for these key patient populations. As I've mentioned previously, Empower 150 has recently demonstrated significant overall survival benefit, and these data will be presented at an upcoming meeting, maybe even in this same room. I want to thank the patients and their families for participating in this trial. It is a noble act, in my opinion, for a patient to participate in a clinical trial. We want to thank all our participating study investigators in clinical sites. Thank you very much.
Thank you, Dr. Sosinski, for an excellent presentation. I'd now like to welcome to the stage Dr. Justin Gaynor from Mass General Hospital to discuss Empower 150.
You got it now.
Good job. Takes a little practice.
Good morning. I'd like to thank the organizing committee for the invitation to present in this exciting session today. Here are my disclosures. So as we've heard from Dr. Gandhi, Dr. Herbst, and Dr. Sosinski, there's ample clinical rationale for the combination of cytotoxic chemotherapy and immune checkpoint blockade. Therefore, I wanted to focus on the other aspect of Empower 50, which is the intersection of angiogenesis and the immune system. VEGF may contribute to an immune suppressive tumor environment via multiple mechanisms, including decreased lymphocyte trafficking, stimulating the proliferation of T regulatory cells and MDSCs, as well as limiting the maturation of dendritic cell precursors. In preclinical models, therapeutic targeting of VEGF can augment the activity of immune-based strategies. This is illustrated by this example. This is in a B16 melanoma model treated with adoptively transferred T cells. And in this model system, VEGF leads to increased tumor control, survival, and importantly, infiltration of adoptively transferred T cells, as shown in the bottom right. Clinically, VEGF has also been associated with a more favorable immune microenvironment when targeted. In the upper left, this is a small clinical trial focused on 10 patients with treatment-naive renal cell carcinoma. In this study, there was a brief bevacizumab run-in period, followed by a period where patients were treated with the combination of bev and atezolizumab. Importantly, in this study, patients underwent serial biopsies, allowing the investigators to assess the impact of bev on the tumor microenvironment. So these biopsies were evaluated for gene expression changes, and the investigators observed that during the Bev run-in period, there were increases in gene signatures associated with T-cell trafficking, tumor MHC expression, and infiltration of tumor-specific T-cell clones. Therefore, as we review the Empower 150 data, we should remember that this is not just a chemo plus IO trial. Rather, there may also be an interplay between PD-L1 and bevacizumab. So today I'm going to focus on three key questions that have been prompted by the presentation by Dr. Szynski and colleagues. The first of which is, did the PD-L1 staining platform influence the initial results in the intention to treat analysis? To date, 4 different PD-L1 staining platforms have been used to evaluate clinical trials of checkpoint inhibitors, prompting questions about the concordance of these assays. Recently, 2 harmonization efforts, the NCCN project on the left and the Blueprint project on the right, have attempted to compare the various PD-L1 staining antibodies. In these studies, they found that the SP142 antibody, which is illustrated by the dark blue in the NCCN project and the light blue in the Blueprint project, identified fewer specimens with PD-L1 overexpression compared to the other diagnostic clones. Next slide. In Empower 150, as highlighted by Dr. Szynski, the Arm B, which included atezolizumab with chemo and bevacizumab, resulted in improved progression-free survival across all PD-L1 subgroups, including the subgroup with negative PD-L1 expression. But in light of the Blueprint data, one is left to question whether these patients would have actually been PD-L1 positive if we used a different antibody clone. And that's really the question mark that prompted the analysis for the SP263 antibody. As shown by Dr. Szynski and colleagues, in this retrospective staining, the frequencies of PD-L1 expression were quite similar with the SP142, and clinically, the results were also consistent across all PD-L1 staining. Thus, I do not believe that the results of Empower 150 were impacted by the specific PD-L1 assays used. Like Dr. Herbst, I do think that Empower 150 and Keynote 189 do prompt the question of whether we actually need to perform PD-L1 testing anymore. In my view, I do think there's still value in PD-L1 testing, particularly in patients who are found to have high PD-L1 expression. The next question I'd like to address is the role of the Empower 150 combination in patients with oncogenic driver mutations. EGFR mutations and ALK rearrangements define distinct molecular subsets of lung cancer and confer sensitivity to treatment with targeted therapies. Unfortunately, patients invariably develop resistance to targeted therapies, as illustrated by the case on the right. Thus, we do need additional effective therapies. Unfortunately, PD-1 monotherapy has had minimal activity in patients with EGFR mutations and ALK rearrangements. On the left is some retrospective data from our institution showing low response rates among these patients. On the right is a meta-analysis of randomized phase 3 studies and one phase 2 study showing that EGFR mutant patients really did not derive a survival benefit with single-agent checkpoint inhibition. Similarly, if you enrich this cohort for PD-L1 expression, the response rates to single-agent PD-1 inhibition remains quite low. And this speaks to the observation that PD-L1 may be a less reliable predictive biomarker in patients with EGFR and ALK. Typically, PD-L1 expression is a surrogate of inflammation, being upregulated in response to interferon gamma from infiltrating immune cells, so-called adaptive immune resistance. By contrast, several preclinical models have suggested that EGFR mutations and ALK rearrangements, the oncogenic signaling induced, leads to upregulation of PD-L1 expression independent of infiltrating immune cells, a so-called innate immune resistance. And it's this situation that may be less responsive to immune checkpoint blockade. When we've looked at a cohort of EGFR and ALK-positive patients, we find that while some actually do express PD-L1, most do not have infiltrating immune cells, again, consistent with innate immune resistance. In the next several talks, we'll be focusing on TMB, or tumor mutation burden, which has also been shown to be an independent predictive biomarker of response to checkpoint blockade. Notably, EGFR and ALK-positive patients tend to occur in patients with a never light smoking history, and we know that those patients tend to have lower TMBs. And so in the bottom panel, this is data from Daniel Tan's group showing that among EGFR mutant patients, there is a low TMB, and this too may underlie the decreased responsiveness to single-agent checkpoint inhibitors. So it's therefore surprising when we see the Empower 150 data, where we see really for the first time in a randomized study, where we see a significant benefit among EGFR and ALK-positive patients. And so the question is, why is this study different? There are a decent number of patients in this study, 108. But we have to ask ourselves whether this cohort is actually really representative of our usual EGFR and ALK-positive patients. I should note that 6 patients, or approximately 18% of ALK-positive patients in this group, had both EGFR and ALK rearrangements. And this is somewhat surprising, as these are generally considered mutually exclusive. And so this raises the question of possible false positive genotyping and whether these patients may have been misclassified. Likewise, about a quarter of EGFR mutant patients had other EGFR mutations, so non-classical mutations, again speaking to, are these truly representative? I think there are a number of open clinical questions, such as the clinical characteristics of these patients, such as smoking status, how many prior TKIs were received, what were their resistance profiles, and at what point in their care did they have PD-L1 testing? Was this pre or post TKI? On a biologic level, I think we should also ask, what was the contributions of cytotoxic chemotherapy here? Did it result in more immunogenic cell death? Or are immune responses more delayed in these patients, and chemotherapy provided some additional therapy while waiting an IO response? Lastly, could there be synergy between bevacizumab and atezolizumab in these patients? So what should we do with our patients? Is this data enough? Well, ideally, we would validate this in another study. Unfortunately, the vast majority of randomized phase 3 studies ongoing evaluating chemo plus IO combinations have excluded EGFR and ALK-positive patients, though there are several studies noted below, as well as several investigator-initiated studies. In the closing minutes, I just wanted to focus on one last question, and what is the context of these data? Throughout this session, we're going to be hearing about various first-line strategies for patients involving checkpoint inhibitors, ranging from PD-1 monotherapy in biomarker-selected patients to IO plus chemo to IO-IO combinations. In the last year, we've heard about many positive studies as well as several negative studies. For the sake of time, I'm going to focus just on the PD-1 plus IO combinations. And really the elephant in the room is, how does Keynote 189 compare with Empower 150? Now, I recognize that cross-trial comparisons come with a number of caveats, but when treating the patients in front of us, these are the things that clinicians do every day. If we focus on the patient populations, very similar patient populations with several notable exceptions. So as was already noted, EGFR and ALK patients allowed in Empower 150. There were differences in CNS metastases. And importantly, Keynote 189 allowed crossover, while Empower 150 did not. Dr. Gandhi presented very impressive PFS and OS data in Keynote 189. Dr. Szynski also showed an impressive hazard ratio for PFS, but we're waiting on the actual OS data. We know it's positive, but how positive? As a clinician, I should also note that the chemotherapy backbone is also important when deciding the choice of regimen, and that in the United States, pemetrexed has been a more common backbone for patients with non-squamous histology in light of its favorable safety profile. So to conclude, Empower 150 was a large, well-conducted study. I congratulate Dr. Sosinski and his colleagues. This is the first randomized study to demonstrate significant benefit with checkpoint blockade in EGFR null patients. We await the OS data, and these results will need to be viewed in the context of the changing first-line landscape, including the recently reported Keynote 189 study. Thank you.
Thank you, Dr. Gaynor, for another excellent discussion on a complicated trial. I'd now like to welcome our third abstract presenter. This is Dr. Matthew Hellman from Memorial Sloan Kettering in New York, who will be presenting on nivolumab plus ipilimumab versus platinum doublet chemotherapy as first-line therapy for advanced non-small cell lung cancer, initial results from Checkmate 227.
Good morning. On behalf of the investigators and patients who have participated in Checkmate 227, it's my pleasure to present the initial results of this randomized phase 3 study of patients with non-small cell lung cancer treated to the first-line nivolumab plus ipilimumab versus chemotherapy. These are my disclosures. The standard of care for patients with newly diagnosed advanced non-small cell lung cancer has been platinum-based chemotherapy or pembrolizumab for the subgroup of patients with high PD-L1 expression. Nivolumab plus ipilimumab are both immune checkpoint inhibitors with complementary mechanisms of action. The combination has demonstrated improved efficacy in several settings, including melanoma and kidney cancer. In non-small cell lung cancer, a previous phase 1 study, Checkmate 12, showed promising efficacy in the first-line setting. This study demonstrated that a regimen including nivolumab given at standard doses and ipilimumab given at reduced dose and frequency was associated with improved efficacy relative to nivo monotherapy and good tolerability at that dose. In that study, activity of the combination was particularly enhanced in those with PD-L1 expressing tumors. Since then, emerging data from a variety of studies have highlighted the potential role of tumor mutation burden as a biomarker for nivolumab plus ipilimumab. In particular, a recent analysis of patients with non-small cell lung cancer treated with nivo plus ipi in Checkmate 12 showed that TMB was a strong and independent biomarker. In small cell lung cancer, an analysis of Checkmate 032, increased TMB was associated with increased benefit, and high TMB identified those most likely to benefit from nivo plus ipi compared to nivo monotherapy. Checkmate 227, though, was designed prior to the emerging data about TMB, and instead originally focused solely on PD-L1. The study design is shown here. Patients with treatment-naive advanced non-small cell lung cancer were screened for PD-L1 expression, and those who were PD-L1 positive were randomized to nivo plus ipi or nivo monotherapy versus chemotherapy. Those who were PD-L1 negative were randomized to nivo plus ipi or nivo plus chemo versus chemotherapy. Patients with EGFR and ALK mutations were excluded. All histologies were included of non-small cell lung cancer and stratified by squamous versus not squamous. Patients randomized to chemotherapy received histology-specific chemotherapy with either cisplatin or carboplatin, plus pemetrexed for non-squamous or gemcitabine for squamous. And based on the initial data from Checkmate 12, demonstrating improved responsiveness to nivo plus ipi in PD-L1 selected patients, the original co-primary endpoint of the study is to examine overall survival of nivo plus ipi versus chemo in PD-L1 selected patients. This analysis remains a co-primary endpoint. At the time of the current database lock, the Data Monitoring Committee recommended continuation of the study, and results of this endpoint are expected later this year or next. However, based on the emerging data about TMB as an effective and independent biomarker for identifying those who are greatest benefit to nivo plus ipi, the study was amended prior to the initial analysis to include a second co-primary endpoint. Here, we examined progression-free survival with nivo plus ipi versus chemo in a predefined population of patients with TMB-high non-small cell lung cancer. To reiterate, the original design of Checkmate 227, examining the benefit of nivo plus ipi versus chemotherapy in PD-L1 selected patients, remains intact and the analysis is ongoing. To incorporate the second co-primary endpoint in TMB selected patients, half of the alpha was allocated to this endpoint. A hierarchical analysis of secondary endpoints in TMB selected patients was planned. Among those secondary endpoints was an evaluation of nivo monotherapy versus chemotherapy in TMB high PD-L1 positive patients, and this secondary endpoint was not met, so additional analyses here are descriptive. An analysis of several previous studies ultimately served to inform the predefined cut point that was applied in Checkmate 227. In particular, previous data from several studies have demonstrated the accuracy of estimating TMB using targeted next-generation sequencing platforms, such as Foundation One, which are now FDA approved and used routinely for the molecular profiling of lung cancers. And an analysis from Checkmate 568 that will be described in more detail by Dr. Ramalingam following this presentation, TMB determined using Foundation One predicted benefit with first-line IPI plus nivo, with an increasing TMB matching increasing response rate until a plateau around 10 mutations per megabase. This cut point was then chosen to define the pre-specified population for analysis in Checkmate 227. Although TMB analysis in Checkmate 227 was pre-specified prior to the initial analysis, the amendment to add this co-primary endpoint occurred after enrollment was complete, so sufficient tissue for TMB testing was not available for all patients at 58%. A relatively modest amount of tissue was required as part of the study, just 10 slides, and some of that was allocated to PD-L1 testing. Of those evaluated by Foundation One, those patients who were high TMB, defined as 10 mutations per megabase, represented 44% of patients with non-small cell lung cancer. Notably, as has been demonstrated in nearly every previous study, TMB and PD-L1 were independent variables. The distribution of PD-L1 positivity was exactly the same in TMB high versus TMB low patients, with no enrichment of PD-L1 expression among TMB high patients. Overall, TMB high represents a distinct subgroup of non-small cell lung cancer independent of PD-L1. Importantly, the baseline characteristics of all randomized patients were nearly identical to those who were TMB evaluable. And this slide shows the progression-free survival of nivo plus ipi versus chemotherapy in both the all randomized patients on the left and the all TMB evaluable patients on the right. Both plots include patients irrespective of TMB or PD-L1. I think there are two important conclusions from here. First, among an all-comer population of non-small cell lung cancer, regardless of TMB or PD-L1, progression-free survival is improved with nivo plus ipi versus chemotherapy. There's nearly a doubling of patients who are progression-free at 1 year with nivo plus ipi. Second, the efficacy of nivo plus ipi versus chemotherapy in the TMB evaluable population closely mirrors the all randomized population, supporting that TMB testing did not skew the analyzed population and highlighting the reliability of the results we'll show here. So with that background and context, we'll move now to the primary analysis. These are the baseline characteristics of patients with TMB high non-small cell lung cancer in Checkmate 227, comparing 139 patients randomized to nivo plus ipi and 160 patients randomized to chemotherapy. Baseline features were consistent with patients with newly diagnosed non-small cell lung cancer, with the accepted exception of increased smokers within this group. Baseline characteristics were well balanced between the two treatment arms. The co-primary endpoint of the study is shown here. Progression-free survival was significantly improved with nivolumab plus ipilimumab in patients with TMB high non-small cell lung cancer, with a hazard ratio of 0.58 and a p-value of 0.0002. The proportion of patients with progression-free survival at 1 year was more than tripled with nivo plus ipi to 43% with nivo plus ipi compared to just 13% with chemotherapy. By contrast, in demonstrating the value of the TMB biomarker and the effectiveness of the pre-specified cut point, there was no difference in progression-free survival with nivo plus ipi compared to chemotherapy in patients with TMB less than 10. The overall response rate to nivo plus ipi in patients with TMB high non-small cell lung cancer was 45.3% compared to 26.9% in patients treated with chemotherapy. Consistent with the transcendent durability that's been so characteristic of immunotherapy, the duration of response was improved with nivolumab, again, nearly tripled compared to chemotherapy at 68% compared to 25% at 1 year. Additionally, the depth of response was significantly improved with nivolumab. 35% of patients treated with nivolumab had more than 50% response in their tumor, compared to just 12% with chemotherapy. And 9% of patients treated with nivolumab had more than 80% reduction in their tumor volume, compared to less than 1% with chemotherapy. An assessment of overall survival in TMB-high patients was planned in the hierarchy of secondary endpoints, but was not formally tested here due to the secondary endpoint of nivo monotherapy versus chemo having not been met. However, to provide a preliminary look at overall survival, an additional database lock was performed in March, specifically for overall survival, and limited only to the patients in the TMB-high group. The descriptive analysis here is early, with 14 minutes of minimum follow-up, more than 50% of the data points censored, and nearly all points beyond 14 months being censored. And yet, there's an encouraging trend in the separation of the survival curves favoring nivolumab, with a current hazard ratio of 0.79. More mature follow-up will be needed in the future to further characterize the survival benefit achieved with nivolumab, but notably the control arm with chemotherapy performed quite well, with a median overall survival of 16 months, which is greater than most other phase 3 studies, and yet still a full 7 months less than was achieved with nivolumab. Returning to the primary endpoint of progression-free survival, PFS was improved within nearly every subgroup examined, including age, sex, geography, performance status, histology, and PD-L1 expression. Taking a more granular look at key subgroups in this study of all non-small cell lung cancers, nivo plus ipi was associated with a similar raising of the progression-free survival curve in both non-squamous and squamous lung cancers compared to chemotherapy. And of particular importance, nivo plus ipi significantly improved progression-free survival in both PD-L1 positive and PD-L1 negative patients, with a striking degree of similarity in both settings. There's a clear plateauing of these curves, which is nearly equivalent regardless of PD-L1. The results here highlight that TMB and PD-L1 are independent biomarkers, that TMB is predictive of benefit with nivo plus ipi irrespective of PD-L1 expression, and that TMB high represents a distinct new subgroup of non-small cell lung cancer. And lastly, in terms of efficacy, we examined PFS of nivo plus ipi relative to nivo monotherapy. Notably, this analysis could only be performed in patients that were PD-L1 positive, as PD-L1 negative patients were not randomized to nivo monotherapy. Yet PFS was improved with nivo plus ipi even within this PD-L1 enriched subgroup. There's a clear stepwise improvement in the 1-year PFS from 16% with chemo, up 13% with nivo monotherapy, and up another 13% with nivo plus ipi, up to 42%, highlighting the distinct contribution of this immunotherapy combination to efficacy in TMB-high patients. In terms of safety, here with a regimen using the reduced dose of ipilimumab that seems optimized for non-small cell lung cancer and improved to the experience in melanoma, nivo plus ipi was well tolerated and similar to our previous experience with Checkmate 12. In this pooled analysis of all patients treated, fewer than a third of patients had any grade 3 or 4 treatment-related events. 17% of patients discontinued either nivo, ipi, or both due to toxicity, and this experience was similar to Checkmate 12 at 13%. Although the rate is higher than with chemotherapy, patients continued on treatment with nivo plus ipi for far longer. The rate of treatment-related death was only 1%. Perhaps most importantly, in terms of immune-related toxicities, skin, endocrine, and GI immune-related AEs were the most common any grade events, although each occurred in a minority of patients and were overall mild. Very few patients experienced grade 3 to 4 immune-related events overall, and nearly all were in the low single digits. Grade 3 to 4 pneumonitis, for example, occurred in only 3% of patients. In conclusion, in this study of patients with TMB-high first-line advanced non-small cell lung cancer, we found that nivolumab plus ipilimumab significantly improved progression-free survival compared to platinum doublet chemotherapy. The breadth, duration, and depth of response were all improved with nivo plus ipi, with more than a tripling of the 1-year PFS compared to chemotherapy. The combination of nivo plus ipi had improved progression-free survival irrespective of PD-L1 expression, histology, and was seen in nearly all subgroups. The combination had improved progression-free survival relative to nivo monotherapy as well, highlighting the distinct value of this combination. Although PFS was improved with nivo plus ipi in an all-comer population, the application of the TMB biomarker effectively identified the subgroup of patients with clinically significant benefit of nivo plus ipi. Overall survival is preliminary but encouraging, with a clear splitting of the OS curves favoring nivo plus ipi. Nivo plus ipi with ipi given a lower dose and frequency was tolerable and manageable. And overall, we believe that this study may introduce two new options for patients with newly diagnosed non-small cell lung cancer. The first is this study demonstrated the clinical value of nivo plus ipi as a treatment option for TMB-high non-small cell lung cancer. The combination provides substantial durable benefit, builds upon the continued progress that we've made through precision medicine and non-small cell lung cancer, spares the use of chemotherapy in the first-line setting, and preserves an effective second-line option if needed. Second, this is the first study to validate the role of TMB with a pre-specified cut point to effectively identify patients at greatest benefit to nivo plus ipi. This result establishes TMB high as a distinct, definable new subgroup of non-small cell lung cancer and validates TMB as an independent, reliable biomarker to be routinely checked. Overall, I believe that this result broadens the clinical actionability of the information that can be derived from routine next-generation sequencing in non-small cell lung cancer. This study and additional details have been published concurrently online now in the New England Journal. These are my colleagues around the world who have led this study, which has been developed and supported by Bristol Myers Squibb. And on behalf of these investigators and study teams, we'd like to acknowledge and thank the patients and their families who have participated in this trial. Thank you very much.
Thank you, Dr. Hellman, for sharing these very exciting results. And to discuss Checkmate 227, please welcome Dr. Nair Rizvi from Columbia, New York.
Hello. Okay, here's disclosures. So TMB is really a surrogate for predicted neoantigens. Traditionally when we think about mutations in lung cancer, we think about driver mutations as they're involved in clonal expansion and they're potentially druggable targets with small molecule therapy. We don't typically think about, or haven't historically thought about, the additional passenger mutations that exist. And these passenger mutations are now clearly becoming important as they are really thought now to be drivers of adaptive immune escape. The majority of missense mutations whereby you change coding are potential neoantigens, but to truly define a neoantigen, the mutation has to both bind MHC and the T-cell receptor with high affinity. So adaptive immune escape from these tumor neoantigens can look like the slide on the left, which is a lung cancer patient of mine with a high degree of T-cell infiltration. And these T-cells produce factors such as interferon gamma that can drive PD-L1 expression. And this immune-infiltrated PD-L1 expressed tumor microenvironment is phenotypically what we classically think about adaptive immune escape. However, TMB and PD-L1 in this data set to some degree, but many other data sets, including 227, do not co-associate. And additionally from this data set, we also see that TMB and TILs do not co-associate. So you can have a tumor with a high mutation burden without immunofiltration, without PD-L1. And I think we're still trying to understand how those tumors evolved. When we look at the Checkmate 026 data, which is nivolumab versus chemotherapy, employing PD-L1 with a 5% threshold, there was no improvement in progression-free survival, but when TMB was applied above an upper tertile threshold of 243 mutations, we saw there was an improvement in progression-free survival. What was interesting is if you look at the subgroup of patients with high TMB and high PD-L1 of more than 50%, those patients did extraordinarily well. whereas tumors that had high TMB and intermediate PD-L1 expression, ranging from 1 to 49%, did not do as well. So I think there's some opportunity for us to try to improve that outcome, potentially with combination therapies. Checkmate 032, which was a small cell lung cancer trial, similarly samples underwent whole exome sequencing. And small cell is interesting because, like lung cancer, it's largely a smoking carcinogen-related tumor, but most 80% of these tumors are PD-L1 0, have absolutely no PD-L1 expression. Nevertheless, when you apply the same upper tertile parameters above 248 mutations, the nivolumab progression-free survival and overall survival did not perform particularly well, but the combination of nivolumab and ipilimumab in this TMB high, PD-L1 negative patient population had a progression-free survival of 7.8 months and a median overall survival for 22 months. So it's clear that ipilimumab is adding something to nivolumab in this scenario. So turning to 227, during the course of this trial, the aggregate TMB data from these trials, as well as 568 and 012, were emerging, and it was clear that TMB was an important story. The co-primary was amended to add TMB PFS as a co-primary, and the analysis was performed using a Foundation Medicine assay, which will be discussed later. Just a few words on that. It's not a straight mathematical conversion. The conversion from 10 mutations per megabase is based on all somatic mutations, missense, synonymous, short indels, and converted to whole exome sequencing with equivalent to 200 missense mutations. That was done in a validated way that will be described later. And these are the data that Matt presented, and you can see the median progression-free survival is significantly better with a hazard ratio of 0.58. The landmark PFS is particularly compelling at 43% versus 13%. And these responses to IPI and Nivo are durable, and so we have nearly 70% of patients who respond who are having durable benefit. The chemotherapy arm really performed as expected, about a 27% response rate, but with IPI and Nivo together it was 45%. So, when we, unlike the Checkmate 026 experience with single-agent nivolumab, where the patients who had PD-L1 expression less than 50% did less well, what was really, I think, one of the more important slides from Matt's presentation is that those tumors that received IPI and Nivo had the same benefit whether they had any level of PD-L1 expression or no PD-L1 expression, and that strong progression-free survival was seen in both groups, really, I think, demonstrating the addition of ipilimumab to nivolumab. So the overall survival data is shown here. It's trending in the right direction. The trial is ongoing, and survival data is maturing. So, of course, we have to think about 227 data in concert with 024 data. As mentioned, this was a TMB selected patient population using Foundation Medicine NGS. Only 60% of patients had material available for TMB evaluation, but keep in mind that the material that was submitted for 227 was 10 unstained slides. Much of the material had already been depleted for more standard EGFR and ALK testing. Nevertheless, the threshold was 200 missense mutations, 10 mutations per megabase. The prevalence of TMB high is 44% versus 30% for PD-L1 high. But if you look at the activity, the response rate, PFS, 1-year OS, although obviously they're different trials, they look fairly strong in both trials. It's also important to note that they're not the same patients. If you look at the PD-L1 selection, if you take the 50% threshold, that's 30% of tumors. PD-L1 less than 50% is 70% of tumors. And then so the TMB high patients represents about 13% really from the 50% group, but 30% of the PD-L1 negative group. So I think that it's an important selection, that an important biomarker to have, particularly for the PD-L1 negative high TMB patients. Toxicity is more. We do see more immune-related adverse events with IPI-Nivo than Nivo. We know that from our own practice. The discontinuation rate treatment-related adverse events leading to discontinuation was seen in 17% of the patients, which is more with nivolumab on its own. But I think we have to really track this trial with longer follow-up. The duration of exposure was 4.2 months. When you looked at the Keynote 024 data when it was first presented and published, the discontinuation rate was 7%. When the data was updated at World Lung last year with additional duration of exposure, it was actually up to 13%. So I think we really have to follow 227 closely with longer-term follow-up in terms of toxicity. Also, the data that was reported in terms of toxicity was in the entire population, not the TMB selected patient population. The TMB selected patients, they're going to be on therapy for longer, and maybe they're having high TMB patients perform differently in terms of AEs as well. So I think we really need that data. So I think just to take a step and try to see how we can learn more about TMB in terms of patient selection, I'm just going to go back for a second to our initial publication around pembrolizumab-treated patients, and we found that above or below the median of 200 missense mutations, we saw differential progression-free survival. We updated this data recently and show with long-term follow-up, half of these patients are still alive based on this TMB selection, I think, which is encouraging. But half of these patients are not alive, and what can we do to understand this further? So our data set was analyzed by the Swanson Laboratory, and they applied an analysis to look at tumor heterogeneity. And it's clear from the patients that had durable benefit with pembrolizumab, these tumors were highly clonal, had very low intratumoral heterogeneity, and did really well. And they actually also had higher PD-L1 expression. The subgroup of a few patients that you see on the right with no durable benefit did have high tumor mutation burden, but they had a significantly higher, not significantly higher, but they had a higher subclone fraction. And interestingly, these tumors had lower or no PD-L1 expression at all. So I think one of the questions around ipi-nivo combinations is, can these drugs be more active in these tumors with a high subclone fraction that respond less well to PD-1 therapy, have less immune infiltration? Our data set was also analyzed by the Greenbaum Laboratory, and they applied an informatics approach looking at the clonality of the tumor to determine a fitness value for each clone, and then each clone was analyzed by its neoantigen repertoire, and the specific endpoints that were looked at were MHC presentation and T-cell recognition probability to develop a fitness score, and those tumors with low fitness did particularly well with a highly significant difference versus those with high fitness tumors. Finally, I think that HLA class 1 is important. Remember that neoantigen presentation is governed by HLA class 1. Each person has six HLA-1 alleles encoded by class HLA A, B, and C. Most people are heterozygous at all loci, but there are some people who are homozygous at HLA class 1. And we looked at, these are mostly melanoma patients, and we looked at the zygosity and outcomes in patients treated with immune checkpoint blockade. And those that were homozygous in at least one locus did less well in terms of immune checkpoint blockade therapy. We also look at tumor HLA. Probably one of the mechanisms of immune escape is HLA loss within the tumor. So either you lose the maternal or paternal HLA class 1, so you reduce your number of presenting HLA alleles to half. And similarly, in the same analysis, we looked at tumors did or did not have LOH and found a similar effect. So both germline as well as somatic HLA is going to be important. Okay, so let's just turn to real world, how we can use this. This is how the workflow in the molecular lab. Tumors are sent first for ALK1, ROS1, EGFR, BRAF testing. The IHC is used, FISH is used, a smaller panel of NGS is used, 50-gene panel, and then maybe as an afterthought, you may send it for more extensive 300 to 500 gene panel testing. I think if we're going to be using TMB clinically, we need to redefine that workflow. I think we are going to need to go straight from sample extraction to NGS library preparation to NGS panels, so we can get not only driver oncogene data, but also TMB data. And this is totally feasible. If you look at the Foundation Medicine data around turnaround times, nearly 80% of tumors are turned around in 10 calendar days or less, and then 30% are less than 7 days, so a week in time. So I think it's totally feasible for us to be getting NGS TMB as well as targeted oncogene data in real time. So how can we put this together? I don't think that we necessarily are ready to use TMB on its own. I think that PD-L1 is also important. So when we think about a TMB high, PD-L1 high tumor, which is about 10% of tumors, I think that we will continue to use pembrolizumab. I think we need to assess the data for nivolumab and ipilimumab in this subset. That data was not reported for the 50% threshold in the 227 presentation. I think it's clear to me that the TMB high, PD-L1 low patients was about 30%, did really well with nivolumab, ipilimumab, and then TMB low population. I think it's a bit of a question mark. I don't know that we know for sure what the experience is with pembrolizumab in those patients, but I think clearly chemotherapy is still a standard of care. I also have my own elephant in the room, and I think my elephant's better than Dr. Gaynor's elephant, but that's just me. And I think the elephant in the room here is that I think that IO and chemotherapy combinations are clearly effective, but I think to interdigitate this data to IO-only therapies, we need TM data from chemotherapy combination trials. And additionally, I think we need to think about TMB more broadly. I think that there's a reason, in my mind, that we've seen negative gastric and bladder and head and neck trials, because those tumors in general have a lower prevalence of tumors that are above the 10 mutations per megabase threshold. So I think we need to focus our trials more around combinations in a TMB select patient population. And I also think that we need to try to use TMB to identify those tumors with lower prevalence of TMB high tumors as a selection criteria, because we can't treat every patient with a 5% tumor with only 5% TMB high with immune checkpoint blockade. The thresholds are likely to be different, so this is just kind of a sort of a starting point, I think. So in conclusion, I think TMB as a biomarker should be a standard of care as an individual evaluation of lung cancer patients. I think it's feasible. We just need to rechange our workflow. Although the TMB was not prospectively defined in 227, although TMB was prospectively defined, the TMB selection was not prospective. So I think we need a prospective trial for confirmation of these results, but I think the data do stand on their own. I think it'd be good to have more data from 227 around the PD-L1 high subset, as well as AE data and TMB high patient population, as well as longer-term safety, as well as efficacy data. And I think this data is potentially applicable beyond advanced lung cancer. We can use it for thinking about adjuvant, neoadjuvant, or consolidation therapy, pan-cancer, and as many in the room know, blood-based TMB is also being explored. I think that TMB needs to be incorporated into IO trials when we evaluate different immunotherapy combinations. I think it's hard to interpret those data without TMB in the background. And I don't think we can stop doing whole exome sequencing and RNA sequencing on these patients, and we need to continue research to develop a more refined TMB assessment incorporating clonality and HLA as well. Thank you.
Thanks, Dr. Risby, for a very insightful discussion. We'll now move to our fourth abstract, which will be presented by Dr. Suresh Ramalingam from Emory in Atlanta. And Dr. Ramalingam will be speaking on TMB as a biomarker for clinical benefit from dual immune checkpoint blockade with Nivo and Ipi in first-line non-small cell lung cancer, identification of TMB cutoff from Checkmate 568.
Good afternoon, dear colleagues. On behalf of my co-investigators, it's my honor to present the results of the Checkmate 568 study with emphasis on TMB cutoff as a predictive biomarker for combination therapy with ipilimumab and nivolumab. My disclosures are shown in this slide. As we've seen in this session, immune checkpoint inhibition is now a proven standard treatment in non-small cell lung cancer. In the frontline setting, monotherapy and combination with chemotherapy are all established treatment approaches. The combination of nivolumab and ipilimumab has demonstrated promising and durable activity in the Checkmate 012 study. And in this study, which evaluated various dose combinations of nivo and ipi, the dose of nivo given at 3 milligrams every 2 weeks and ipi given at a dose of 1 milligram every 6 weeks was chosen as the optimal regimen for further development. Despite these exciting developments, there is a clear need for development of novel biomarkers that will help us select patients for these innovative treatment approaches. And it is in this context that TMB, which has been shown as an emerging predictive biomarker for response to immune checkpoint inhibition, was studied in the 568 study. The Checkmate 012 trial had earlier demonstrated that TMB was able to identify patients who are likely to benefit from the combination of ipi and nivo. On the PFS curve you see, the patients with higher TMB were associated with better progression-free survival compared to those with lower TMB. We also saw that TMB was not clearly associated with PD-L1 expression. Tumors with high PD-L1 expression had low TMB, and tumors with high TMB had low PD-L1 expression. The Checkmate 568 study is a large single-arm phase 2 study in the frontline treatment of patients with stage 4 non-small cell lung cancer. The inclusion criteria are outlined in the slide. These were patients with newly diagnosed stage 4 or recurrent stage 3B disease that had not received prior systemic chemotherapy. Patients with known EGFR and ALK genetic aberrations were excluded from the study. Patients were required to have an ECOG performance status of 0 to 1, and patients were chosen regardless of PD-L1 expression status. The treatment consisted of nivolumab given at 3 milligrams per kilogram every 2 weeks, and ipilimumab given at a dose of 1 milligram per kilogram every 6 weeks. A total of 288 patients were included. The treatment was continued until disease progression or unacceptable toxicity or to a maximum of 2 years. The primary endpoint of this study was to determine the objective response rate in both the PD-L1 greater than 1% and PD-L1 less than 1% population. Key secondary endpoints included progression-free survival, overall survival, and evaluation of biomarkers, particularly TMB. Responses were conducted by blinded independent radiographic review, and PD-L1 expression was assessed by immunohistochemistry on the 28-8 immunohistochemical test. Here we show the TMB analysis that was performed for the study. The Foundation 1 CDX assay was chosen to assess TMB in patients in the 568 trial. This assay uses next-gen sequencing to detect substitutions, insertions and deletions, and copy number alterations in 324 genes and select gene rearrangements. TMB was assessed as the total number of synonymous and non-synonymous variants that occurred at greater than or equal to 5% allele frequency after filtering out germline mutations. The final report is noted as the number of mutations per megabase. Of the 288 patients that were enrolled to the trial, samples were available from all of them. Of those, 252 samples were evaluable for PD-L1 expression assessment. And of those patients, the PD-L1 assessment was successfully done in 88% of the patients. Tumor specimen for TMB evaluation was available for 120 patients. Of those, 98 were found evaluable for TMB, and the testing positivity was 82%. 95 patients, or 33% of all treated patients, had data for both TMB and PD-L1 expression. The patient baseline characteristics are shown here for the entire study in the first column for the 288 patients. You also see the baseline characteristics for PD-L1 evaluable group and the TMB evaluable group in the next two columns. Overall, the patient baseline characteristics for the TMB evaluable group and the PD-L1 evaluable group are comparable to what you see with the overall patient population. The percentage of patients with squamous histology was slightly higher at 35% compared to 26% in the overall group for patients with TMB evaluable disease. Among the TMB evaluable group, 49% of the patients had equal to or greater than 10 mutations per megabase, and the remainder had less than 10 mutations per megabase. PD-L1 expression in the TMB evaluable group was less than 1% in 43% and greater than or equal to 1% in 57% of the patients. The distribution of tumor mutation burden in the 568 study is comparable to prior reports. On the orange, we show the distribution from the Checkmate 026 study that has been published earlier, and in the green is Checkmate 227 study that was just reported by Dr. Matt Hellman. Once again, we saw that there was no clear association between TMB and PD-L1 expression. There were many tumors with high TMB that had low PD-L1 expression, and conversely, many tumors with low TMB that had high PD-L1 expression. The objective response rate, which was the primary endpoint, was 30% for the overall treatment population. In the PD-L1 evaluable group, it was 29%, and the TMB evaluable group response rate was 28%, thus showing that these two groups had comparable outcomes as patients for the entire ITT population. The overall objective response rate for patients with high PD-L1 expression at greater than or equal to 1% was 41%. In the PD-L1 negative group, the objective response rate was 15%. Here, we looked at various tumor mutation burdens thresholds and their association with objective response rate. In the group with less than 5 mutations per megabase, the objective response rate was 9%. In the group with 5 to 10 mutations per megabase, the objective response rate was 15%. The patient group that had 10 or more mutations per megabase had a 44% response rate. And for the group that had the highest greater than 15 mutations per megabase, the response rate was comparable to the greater than 10 mutations per megabase group. This defines a mutation threshold of 10 per megabase as a potential predictive marker for the combination of ipilimumab and nivolumab. We then looked at the receiver operating curve characteristics, looking at both PD-L1 as a predictive biomarker and TMB as a predictive biomarker. As you can see in the TMB part, a mutation threshold of 9 to 10 mutations per megabase was seen as a helpful classifier identifying patients at higher likelihood of benefit. In the PD-L1 expression group, no such cut point was identified. The progression-free survival for patients based on TMB is shown in the slide. For patients with high TMB, the 6-month progression-free survival rate was 55%. For patients with low TMB, the 6-month PFS rate was 31%. The median PFS for the high TMB group was 7.1 months, and for the low TMB group, it was 2.6 months. These results are very consistent with the Checkmate 227 data that you just saw earlier presented by Dr. Hellman. The 6-month PFS rate for the high TMB group in both of these studies was 55%. And the 6-month PFS rate for the low TMB group was 31% in our study and 25% in the Checkmate 227 study. Notably, the median PFS was also comparable at 7.1 months for the high TMB group in the Checkmate 568 study compared to 7.2 months in the Checkmate 227 study. Here you see the outcome for TMB high and low patients as a function of PD-L1 expression. In patients with low PD-L1 expression, those with a high TMB had a response rate of 47%, whereas those with low TMB had a response rate of only 5%. In the high PD-L1 expression group, patients with high TMB had a response rate of 42% compared to 18% for patients with low TMB. This shows that the response rates achieved with high TMB are similar both for PD-L1 positive and PD-L1 negative patients. This slide shows the ROC curve characteristics for TMB in both PD-L1 low and PD-L1 high patients, and you see that TMB was an informative classifier for response to Ipi and Nivo in both groups of patients. The safety summary from the Checkmate 568 study are summarized here. 80% of the patients experienced at least one treatment-related adverse event. The most common treatment-related adverse events were fatigue, diarrhea, pruritus, and nausea, and these were all primarily grade 1 or 2 in severity. Most of the grade 3-4 toxicities that were noted were all less than 5% of the patients, with the exception of increased lipase, which was seen in 7%. There were 4 study-related deaths reported, 1 each due to cardiac arrhythmia, pneumonitis, hypoxia, and another unidentified cause. When we look at treatment-related adverse events specifically related to immune checkpoint inhibition, we see that the most common toxicities are skin, GI, and endocrine. And once again, these were all grade 1 or 2 in severity, with rest of them being seen in less than 5% of the patients. Pulmonary toxicity was seen in 7% of all grades and 2% of grade 3 or 4 severity with the combination of Ipi and Nivo. So in conclusion, the Checkmate 568 study showed that nivolumab given at 3 milligram per kilograms every 2 weeks and ipilimumab given at 1 milligram per kg every 6 weeks was effective, was tolerated well, and was consistent with previous reports using the optimized dosing regimen. The objective response rate was higher in patients with high TMB. For patients with high TMB, defined as greater than or equal to 10 mutations per megabase, the objective response rate was greater than 40%. And in this study, 49% of the patients had the mutation threshold of greater than or equal to 10 mutations per megabase. And consistent with previous studies, TMB and PD-L1 are independent biomarkers. PD-L1 and TMB identified distinct and independent populations of non-small cell lung cancer, and they are both independently associated with enhanced objective response and progression-free survival with the combination of Ipi and Nivo. Based on these, the TMB cutoff of 10 mutations or greater per megabase was chosen to pre-specify the high TMB population for the PFS co-primary endpoint in the Checkmate 227 study, which results were just published in the New England Journal today. We would like to thank all the investigators who participated in the study, the patients, their families, the clinical trials coordinators and the clinical trial teams, and our collaborators in Foundation Medicine, DACO, and BMS. Thank you for your kind attention.
Thank you, Dr. Ramalingam. I am now thrilled to introduce our discussant, Dr. David Rim from Yale Cancer Center, who will discuss Checkmate 568 and TMB.
Hi, I'm Dave Rim. I'd like to thank the organizers for inviting me to give this discussion. I don't think they know I'm a pathologist. This is a cancer therapy session, isn't it? But what I'd like to talk about is tumor mutational burden as a biomarker, and that's why I think they invited a pathologist to discuss a biomarker. These are my disclosures. So, as we just heard, this is TMB is actually has a good effect on progression-free survival, where we look at the median TMB and show that, in fact, it's higher. The survival is quite a bit higher than progression-free survival in patients with low TMB. And in fact, shown in this original Checkmate 12 trial, there was also an independence between TMB high and PD-L1 high, PD-L1 high being here, TMB here. For this trial, we looked at a single-arm trial. Now, this is a little bit concerning to use a single-arm trial when you want to have predictive value. So note that when you have a single-arm trial, an interaction term cannot be calculated, and therefore you cannot technically say predictive value if you're a biostatistician. We'll talk about that more. The other thing that they showed, or that Dr. Rummelingen showed, is this ROC curves. It's interesting to see that they're using an ROC curve to define the mutation, the cut point for how many mutations per megabase are required to define TMB, but that the number of patients were quite a bit lower than the number of patients in the PD-L1 arm. It's also interesting to note that the AUCs, or the area under the curves, are approximately equivalent. So, if that's the trial for a new biomarker, what do we think? The first is, I think there's a few reasons for enthusiasm about TMB. TMB is a compelling biomarker for both response and PFS. Specifically, if you look at response, you can see even in the patients who are high for PD-L1, where PD-L1 is a biomarker, TMB is also still a biomarker, and in fact even better. And in fact, most notably in the patients who are low for PD-L1, these are patients that would not otherwise be qualified for therapy in current standards. There's a very high level of response. Also note that when we look at PFS, the 6-month 55% median, 6-month survival compared to only a 31% survival for patients with TMB less than 10 mutations per megabase. So I think the other thing that is enthusiastic is that this is really a new biomarker in terms of its complementarity with respect to PD-L1. This was shown just by Dr. Rummelingen just now, showing that there's actually no relationship. The R value is 0.16, and that you can see that all the cases that have high TMB are pretty low for PD-L1, and similarly, very few cases with high PD-L1 are above the 10% cut point. This is not new, actually, but it's confirmed what we've seen in the literature, and previously shown by Rizvi et al. Showed that there was not really a relationship between PD-L1 and TMB, and similarly in work in our own group led by Scott Gettinger and Kurt Schalper, we see no relationship between PD-L1 expression and TMB. What about reasons for concern? I'm actually quite concerned about this test. TMB is interesting, but how robust and reproducible is this test? And then, I'm not a biostat, but I have a number of biostatistical concerns about the study just shared with you. And finally, PFS is good, but what about OS? So what is the depth of coverage? What is the mutation adjudication? That is, how do you know whether something's a mutation or whether it's simply a polymorphism? And this needs to be addressed, not just in one assay, but in the assays that are done in the thousands of labs around the world that could eventually do TMB. What's the reproducibility of those assays between samples and methods? Is this a large sample? Is a lot of tissue required? We see TMB as it's only done on 34% of the cases, and in Checkmate 227 in 58% of the cases. So in 658 anyway, or 568 anyway, only 34% of the cases had sufficient. So this is what we look at as pathologists who do molecular pathology. This is an IGV plot of the mutations. And so let's say we have 10% of the tumor is mutant. So most of it's going to be wild type. So how many GCs do we need before we say this is actually a mutation? And what color do you use? What mutation color do you use? And then what percentage of tumor do you need to have present compared to normal tissue? All these things are poorly defined and make assessment of TMB very non-reproducible amongst different assays. The discovery standard for most assays is where you use 10 or 30 coverage. But in our CLIA lab, we use 500 to 1,500 fold coverage. That is how many times we cross that same region. And to call a mutation, we like to see coverage in the hundreds or more fold, depending on the percentage of tumor. So this is a challenge that TMB has sort of swept under the rug a little bit, the proponents of TMB, but I think we all need to be very aware of as we evaluate the value of TMB. Secondly, when you compare TMB to the Foundation 1 panel, as was done in Checkmate 26, you can see it's actually, even these two tests that are highly similar, misclassify 10% of the cases. So 9% of the cases are discordant depending on whether you did the Foundation 1 assay compared to the total exome sequencing, which was done in the same cases in Checkmate 26. And finally, if we look at a report, this is actually a Foundation Medicine report, you can see that they put a lot of different cut points in. Okay, it's good. We established a cut point of 10 megabases, but will this cut point stand, especially given the press release where Bristol Myers has now announced that they're going to partner with TrueSight Oncology for their 500 assay, which is a completely different assay than the FMI assay. And it raises the question, are those assays going to be similar? Is 10 still going to be the cut point? I don't know the answer to that question, but I think we should ask. Okay, so I'm not a biostatistician, but some of my friends are. And in fact, I'm concerned about a few things that I've seen with TMB and biostatistically. First of all, if you look at the early evidence for TMB, they all included these high patients, these patients that are hypermutators. In fact, they even had to break the y-axis to show how high these are, and then they used the mean. Again, here's another example where high levels of TMB were thrown in the responders, but you don't necessarily see those hypermutators in the non-responders. Well, we already know that hypermutators are going to respond. So really, if we're going to evaluate TMB, it's more fair to evaluate it in a way that excludes the hypermutators. All these patients up here are out on the skewed part of the curve. We really should eliminate those when we're evaluating TMB, and we should either use the median, which was actually done in 227, so to their credit, but when we think about this, we really probably need to exclude the hypermutators. True, there's very few in lung cancer, only about the same number as ALK or ROS. How about the interaction term? So how many people know what an interaction term is? Okay, not that many, because it's a little bit sophisticated, but if you live in the biomarker world, the interaction term is very important. It's a difference between being predictive and prognostic. If you're prognostic, you can see that you have a treatment and you have a biomarker. And if the biomarker and the treatment are parallel, then it's prognostic but not predictive. What you have to show for predictivity is that you see all three of the curves are low: biomarker, treatment high, treatment low, and the only curve that's high is the patients that are treated and positive for the biomarker. So there's a statistical test for tests of that, and that's called the interaction term. An interaction term was not provided in 658, so while they can claim they're a biomarker, they can't yet claim they're a predictive biomarker. Now, I had a little discussion by email with Matt Hellman, and I can assure you that, in fact, they are a predictive biomarker in 227. We don't have that data from this 658 study. Finally, what about PFS? PFS is good, but what about OS, rather? So this was Checkmate 26, and this is what got us all excited about TMB, showing in the patients with high tumor mutation burden, there was a significant difference, whereas low mutation burden, it flipped. But then if you looked at OS, in fact, those survival curves don't even look promising. Now, in 227, the survival curve does look promising, and there is some separation, but that trial is really immature to validate OS. In our own study at Yale, we found that progression-free survival was statistically significant, but overall survival wasn't. I'd like to raise the possibility that what we're seeing is going to be seen in many studies as we let overall survival mature. And the reason for this, I think, is because when you have a tumor with a lot of mutational skill that has a high tumor mutation burden, that tumor can also mutate further to even avoid immune therapy or become mutant and thus further become resistant to immune therapy. We'll see as time goes on. So how do I summarize? TMB is a biomarker and is complementary to PD-L1. This is interesting. TMB has not been shown to be a predictive marker. Well, actually it has. It just wasn't in there, but Matt Hellman assures me that it is. The interaction term has been calculated. TMB is not standardized. This is going to be the biggest challenge for TMB. There are lots of labs that want to do this as an LDT. There are lots of different ways of doing TMB, and a cut point of 10 in one assay is not a cut point of 10 in another assay. And we have to really make sure that our pathologists know what we're up against when we do TMB. I'm not even sure it will be standardizable, but certainly not standardized yet. TMB is associated with PFS, not OS. I talked about that. And sort of my elephant in the room, and I don't even have a picture of an elephant, is the fact that TMB costs about 5 or 10 times the amount of an IHC and uses 10 times as much tissue as a PD-L1 assay. This is cost, not charge. We won't even go into charge. So final summary, TMB is very provocative, warrants further study and especially standardization before we start using it in the clinic, and further prospective testing. Is TMB ready for prime time? I don't believe so. I think it's not ready yet for use for patient care. I'd like to end by thanking the lung cancer group at Yale, my friends who We work together on lung cancer and also in my lab, and thank you for your attention.
Thanks, Dr. Rim, for an excellent talk on TMB. Now for our fifth and last abstract of this session. This will be presented by Dr. Drew Pardal from Johns Hopkins. His abstract is titled Neoadjuvant PD-1 Blockade in Resectable Lung Cancer. Unlike the previous four abstracts, this study does not involve an immunotherapy combination, but it does address a critical question in the field, which is how to expand the benefit of immunotherapies beyond advanced lung cancer and to patients with early stage and potentially curable disease. Please welcome Dr. Pardal.
Thanks. Thanks so much. It's my honor to present the final results of the first clinical trial of neoadjuvant PD-1 blockade in resectable lung cancer. This was a signature trial in our Stand Up to Cancer Research Institute immunotherapy dream team, and it was co-PI'd by Patrick Ford at Johns Hopkins Bloomberg Kimmel Institute for Cancer Immunotherapy, and Jamie Kraft at Memorial Sloan Kettering. These are my disclosures. So every day, thousands of patients who are operated on for so-called localized cancer will be told by their surgeons that we got it all. Unfortunately, for many of these patients, that's actually not the case, because small numbers of cells from their primary tumor have traveled systemically and formed micrometastases, and these are what will relapse and ultimately kill many patients. In the case of lung cancer, if you look at the group that are surgically resected dependent on stage, somewhat less than half of those patients will actually be cured by surgery, and the remainder of patients will relapse. This is why perioperative chemotherapy has been recommended in resectable stage 1B to 3B cancer, but again, the 5-year survival rate is still less than 50%. And this is actually the comparison between, from the Lancet, between patients that do not receive versus do receive preoperative neoadjuvant chemotherapy. And you can see that the improvement in results with neoadjuvant chemotherapy in operable lung cancer are unfortunately relatively minimal. So our rationale for performing this clinical trial with neoadjuvant anti-PD-1 was completely different than the conventional use of neoadjuvant chemotherapy. The hypothesis on which this trial was created is that there are tumor-specific T cells that live in the tumor, but in many cases they're restrained from killing the tumor by their PD-1 being engaged by PD-L1 in the tumor microenvironment. The notion then is that if one can block this inhibitory interaction, that will initially result in an activation and expansion of tumor-specific T cells first in the tumor, and that these will essentially spill out of the tumor, go into the blood, circulate through the body, and ultimately these activated tumor-specific T cells will hopefully seek out distant micrometastases and intercept them from growing and ultimately causing relapsed cancer in these operated patients. So the design of this trial is as follows. Patients with newly diagnosed resectable stage 1 through 3 lung cancer were treated on 4 weeks before surgery and 2 weeks before surgery, 2 doses of 3 milligrams per kilogram IV of nivolumab. And then following surgery, they received standard of care post-operative treatment. The primary endpoints for the study were safety and feasibility, in particular drug-related adverse events, and the feasibility of resection without extended delay. I should say that initially when this trial opened, our thoracic surgeons were very reluctant to enter patients on this trial because they were worried that this would delay surgery. Exploratory endpoints involved analysis of the pathologic response, in particular with a focus on major pathologic response, defined as tumor cells representing less than 10% of the viable cells in the resection specimen. This we felt was important because it had been shown that MPRs with neoadjuvant chemotherapy are associated with improved recurrence-free and overall survival. We also explored genomic predictors of response and immunologic evidence for induction of systemic anti-tumor T-cell responses. Our goal was to enter, which we achieved, was to enter 20 patients to be completely resected. 22 patients were enrolled. 1 patient was withdrawn because the diagnosis turned out to be small cell lung cancer. Of the 21 non-small cell lung cancer patients entered, 20 all came to surgery. 20 were resected, 1 was not resected due to tracheal invasion. Shown on the right here is the distribution of ages, gender, non-small cell subtype, and clinical stage in this clinical trial. With regard to feasibility and safety, importantly, nivolumab did not delay or interfere with surgery in any patients. There was 1 death post-operatively during the safety period. This was unrelated to study drug or cancer and was unfortunately the sequelae of a traumatic fall. And I should say that these days our thoracic surgeons really don't like to operate on lung cancer patients without them getting a neoadjuvant immunotherapy anymore. So it's been a little bit of a sea change. Radiographically, of the 21 patients that were treated during the 4 weeks between treatment initiation and surgery, there were 2 partial responses. These are shown here, but the vast majority had radiographically stable disease. In other words, there wasn't much of a change in their radiology, in their scans, over that 4-week period. But because they're getting their resections, we have the opportunity to actually look at the whole tumor and ask what's actually happening in the tumor. And when we do that, the story is very different. What we found in a large proportion of cases, and I'll give you in a moment the summary, was a tremendous infiltration of lymphocytes into the tumor. So here's an example of a multispectral imaging 7-color done by Trish Cottrell and Janice Taub in a particular patient. This is pre-treatment. This is a tumor nest. The orange is basically all tumor cells. And you can see that there are relatively few CD8 positive T cells shown in green that have infiltrated into the tumor. However, post-treatment, this is the surgical resection, you can see that these nests of tumors have been totally flooded with CD8 positive T cells, many of which expressing PD-1, but that PD-1 is not able to be engaged to turn off the T cell because the nivolumab is blocking that interaction. The pathologic response in these tumors is very distinct from what you see with neoadjuvant chemotherapy, and I'll direct your attention to Trish Cottrell's poster in this afternoon's session, in which she describes in detail the quantitative analysis of the neoadjuvant response in tumors to anti-PD-1. So this is the summary of the data. Here, regression is the percent pathologic regression, again with major pathologic response representing less than 10% of all of the viable cells actually being tumor cells. 9 out of the 20 patients, or 45% of the patients, achieved a major pathologic response, including patients with different histologies, including a never smoker patient. And 3 out of the patients actually had a complete pathologic response in their resected primary, which means that there wasn't a single living tumor cell that was able to be discerned. You heard from the last 2 presentations about the correlation between total mutational burden and progression-free survival in patients treated with nivolumab in the metastatic advanced setting in lung cancer. It turns out that if one looks in this neoadjuvant setting, there is indeed a correlation between total mutational burden and the level of pathologic response, such that in this group of 11 analyzed patients, if you had a TMB over 250, you had a major pathologic response. If you were under 100, your level of pathologic response was less than 50%. Again, small numbers, but suggests that this correlation is worth continuing to be explored even in this early neoadjuvant setting. Now, having shown that lymphocytes infiltrate the tumor, we also wanted to determine immunologically whether these lymphocytes could leave the tumor and circulate systemically. Relatively recently developed technologies termed TCR-seq allow us to actually track specific T cell clones by virtue of sequencing the CDR3 region, which is generated in the T cell receptor by the rearrangement that creates the tremendous diversity in T cells in their T cell receptor. So by sequencing this complementarity determining 3 region, this region between the V region and the C region, we can actually follow specific T cell clones and determine clonality, particularly looking at expansion of particular T cell clones. In addition, each CDR3 sequence essentially represents a barcode that we can use to look in the tumor or in other blood samples to actually follow what happens to individual T cell clones. So this is just to give you an example of what we saw in one patient. These are 8 specific T cell clones that were shared between the tumor and the blood in that patient. Just prior or at the initiation of therapy, these T cell clones are barely detectable, under 0.01% in the peripheral blood. But now, just 2 weeks after the first dose, about the time of the second dose of anti-PD-1, 5 of the 8 clones have now increased significantly in the peripheral blood, and the remaining clones by the second dose right before surgery have increased significantly in the peripheral blood relative to pre-treatment, and even now 44 days after surgical resection, they still remain in the peripheral blood. In fact, if patients get a major pathologic response rate, those patients have a much higher proportion of T cells from their tumor that you can demonstrate are shared in their peripheral blood relative to patients that did not have an MPR, suggesting that more lymphocytes into the tumor upon nivolumab treatment results in more of those lymphocytes spilling out into the peripheral blood. Now, the question is, what about T cells that actually recognize mutations in the tumor, true tumor-specific neoantigens? So Kelly Smith and Franck Husseau developed a new T-cell assay that they call Manifest for mutation-associated neoantigen functional expansion of specific T cells. We just call it Manifest. It's actually 3 simple steps. One applies an algorithm to predict HLA binding of candidate peptides incorporating mutations derived from whole exome sequencing. So this is basically whole exome sequencing followed by algorithm. One then synthesizes the top 50 or so candidate peptides and tests them in a simple one-step T-cell culture. And the analysis of T-cell reactivity to a given neoantigenic peptide is done using not cytokine production as it is commonly with ELISpot or intracellular cytokine staining, but rather is done looking at expansion of individual T-cell clones using this TCR-seq technology. And by doing this, again, we can quantitatively prioritize the level of reactivity against particular neoantigens through level of clonal expansion, diversity, and richness of the repertoire, and again, using the barcoding function that TCR-seq gives us through the CDR3 region to analyze presence within the tumor. So we'll show you just one example of a patient that had a pathologic complete response to neoadjuvant nivolumab treatment. This is an example of a manifest assay on this patient on their peripheral blood, showing that here 3 T-cell clones expand selectively in vitro in response to this one particular mutant peptides, and these are the CDR3s. Now, again, using the barcoding function, we can go back to the original biopsy of the tumor, and what we see is that collectively, these 3 T-cell clones represent 1.6% of the total infiltrating lymphocytes in the tumor, yet they're barely detectable in the normal lung. We can detect them in the draining lymph node. If we look in the peripheral blood, we can see that this clone, starting here at this level in the peripheral blood pre-treatment, jumps up over 10-fold within 2 weeks. These 2 clones take a little bit longer. They take 4 weeks to jump up from essentially non-detectable in the peripheral blood now to 0.01%. So indeed, this kind of a technology has allowed us to demonstrate specifically that indeed neoadjuvant anti-PD-1 treatment is first inducing expansion of tumor-specific T cells in the tumor, and then a subset of those tumor-specific T cells are migrating out into the blood. Now, ultimately, what's most important for patients is, does this translate to greater relapse-free survival and greater overall survival by intercepting outgrowth of these tumors? Now, this is obviously a small study, And it's still relatively early, but this is now the overall survival data as of a week and a half ago. As you can see, our patients have been followed out from surgery from between 1 year to now, some of them going out over 2 years. And among the resectable patients, this was the one unresectable patient. At this time, there have been only 2 patients that have died. This was the patient that died, unfortunately, due to a traumatic head injury without cancer. There is, at this time, only 1 patient that has died from relapsed cancer, and the vast majority of our patients have not had any relapses of their cancer to date. Again, this is small and still relatively early, and so we can't yet make any conclusions. But some of the early results that have been presented from this trial have launched roughly 75 neoadjuvant clinical trials now in 8 different cancers. So over the next 2 to 3 years, we should determine whether, in fact, these promising initial results are reproduced. So in conclusion, nivolumab prior to lung cancer resection did not delay surgery in any of the treated patients in this cohorts. There were no unexpected safety signals. 45% of resected tumors demonstrated a major pathologic response. There was robust infiltration of PD-1 positive T cells in the resected tumor after 4 weeks of anti-PD-1 treatment. Pathological responses correlated with mutational burden. There was direct evidence for induction of tumor neoantigen-specific T cells, and clinical follow-up is encouraging. I want to thank, in particular, Stand Up to Cancer and the Cancer Research Institute that partnered to fund our immunotherapy translational dream team, Longevity, LCFA, and IASLC, the Bloomberg Foundation, Bristol Myers Squibb for providing nivolumab, importantly, our patients, research staff, and our collaborators. I want to give a personal shout out to the Cancer Research Institute, who gave me my first grant ever 30 years ago when I was a struggling assistant professor that had just run out of my dowry money. So thanks to them, I'm still standing here 30 years later to be able to give this presentation. Thank you.
Thank you, Dr. Pardal. Now to discuss this final abstract, I am very happy to invite Dr. John Haymack from MD Anderson to the podium, and just wanted to make a special thanks to Dr. Haymack for accepting our invitation to serve as a discussant on very short notice.
Thanks, Alice. Okay, well, good afternoon. I'd like to thank the organizing committee for the opportunity to wrap up this very memorable session and discuss this important and exciting abstract. Here is my disclosure information. So let me start by giving you some context for the treatment of early-stage non-small cell lung cancer. The primary goal of adjuvant therapy is to eliminate micrometastatic disease. So here you can see a tumor, you can see some micrometastases. Start with resection, you see the entire left lung is gone, and then adjuvant therapy has the goal of eliminating those. Now, how well does this work? Well, the answer, unfortunately, is not very well. Adjuvant chemotherapy prolongs overall survival and reduces the likelihood of recurrence by about 5% at the end of 5 years of therapy. And despite that marginal gains, of course, has become part of the standard treatment for lung cancer. Now, what about neoadjuvant? Does that do better? Well, to remind you here, with the neoadjuvant therapy, you're giving the treatment first. The tumor may respond. You may have an effect on micrometastatic disease. And you may also have a smaller surgery from what we call downstaging. So this is a potential advantage of neoadjuvant therapy. But of course, this comes with a delay, and things can happen during the delay in treatment. Now, how well does neoadjuvant chemotherapy work? about as well as adjuvant therapy. So here I'm showing you a meta-analysis from a number of different neoadjuvant series. And the hazard ratio here for overall survival, 0.87, is almost identical to that of adjuvant therapy. So there's really comparable benefit for the two approaches when it comes to chemotherapy. Now, could immunotherapy actually improve things? Well, there's a number of reasons to believe that it could. I'm pointing out here one of those reasons is work led by Limo Chen and Don Gibbons. And they've shown here that the tumor cell upregulation of PD-L1 is a critical step for enabling the spread of micrometastases and their survival. So PD-L1 is an enabler of metastases. So that brings us now to the current abstract. And I think if we view this as a journey towards the incorporation of immunotherapy into early-stage lung cancer, today's abstract will be viewed as having advanced us several important steps along that journey. The first question that this study does answer is neoadjuvant immunotherapy safe? And the answer you can see there is yes. There's been no major delays in the treatment. I hear from my surgical colleagues the tumor does change in character sometimes, but nevertheless surgery is certainly possible, but no major safety signals yet. Next question, is it active? And the answer here so far is yes, and it's important to say that it's a modest activity by standard RECIST criteria of tumor shrinkage, but really impressive activity based on major pathologic response rate. And you heard from Dr. Pardol already. Virtually all patients had some evidence here of tumor shrinkage and pathologic response. If you use 10% as a cutoff, you can see there those that have major pathologic response. Now, as you know, this isn't a RECIST response, so what's the significance of major pathologic response in the setting of neoadjuvant therapy? Well, we know the answer for chemotherapy. I'm showing here two separate studies that show that response in terms of major pathologic response with the 10% cutoff is associated with significantly better outcomes in early-stage lung cancer patients. Now again, this is with chemotherapy. There's no reason to believe immunotherapy would be different, but it is possible that the criteria we would use for assessing major pathologic response may need to be modified to reflect the impact of immunotherapy. So the next question is there evidence of enhanced anti-tumor immunity specifically? And this is where I think this work really represents a tour de force. The answer is yes, but it's not definitive. And I think the assessment of the MANA here may be the most important innovation within this study. And so just to remind you from the slide from Dr. Pardol, here they're stimulating with predicted neoantigen peptides, the T-cell populations, and looking at which ones become activated. And when they take those activated ones, we see that with nivolumab there is an increase, and that subsequently comes down after resection. Now, it is worth pointing that there are some caveats to this. Only one of the 50 peptides that were tested were positive. All these were predicted to be neoantigen. So the vast majority of predicted peptides, we don't see activation of T cells. And the vast majority of T cells are not recognizing this or any of the other tested antigens. So I think this highlights, while this is a major advance forward, I think, in terms of the approach, clearly improvements are needed for better identifying TILs and TCRs and pairings of those that specifically have anti-tumor activity. Now, why is that important to be able to identify TILs that specifically have anti-tumor activity? And you'll recall from the prior slide, when the tumor was resected, that you didn't even see this particular TIL still there. Well, I view a clinically feasible approach for identification of MANAs and matching TCRs to become a foundation for future personalization of immunotherapy. And let me give you some examples. Here, if we can routinely identify antigenic peptides, this may become important for monitoring anti-tumor immunity and for developing vaccines to boost immune surveillance in a personalized way. Again, this would be one person's vaccine. If we can identify TCRs routinely, this would enable the transduction of TCRs as personalized adaptive T-cell therapies, and there's a number of groups actively working in this area. And finally, if we can figure out which TILs actually have the anti-tumor activity, this could dramatically enhance our ability to do more effective TIL therapies. But I will point out, this is really a huge challenge at a number of different fronts, and the group here has made some major advances on that front. So now, how do you make sense of all this TCR data? And you heard the results at TCR-seq from Dr. Pardol. Well, there's a number of different efforts in this front. I'd like to point out one from Mark Davis's lab at Stanford. So here what they're doing is looking at structural motifs within the TCR and trying to group them together on functional or structural motifs and do a clustering. So instead of just looking purely at sequence, you ideally there would have clusters of functional TCRs that are doing different things. For example, recognizing viral antigens. Now, building on this approach, Alex Rubin, Jay Zhang, and others in our group have looked at lung and tumors and look at which TCRs are shared and which ones are distinct. Okay, and I hope somebody can click in the charger there. And it's noteworthy that among the shared TCRs, the majority of them are predicted to be against viral antigens. So if you think about a normal lung, it's got all these T cells hanging out, and all their lives they've been fighting these viral infections. But even within the tumor, a significant portion actually have these motifs, may actually be antiviral ones. You could think of these as antiviral T cells that got caught up in all the excitement and have just gone along for the ride with having a tumor there. But they're unlikely to be productive T cells that are actually fighting the tumor. So now what if you take the ones that may be productive, the non-viral motifs, and look here? Well, if you do a comparison of the productive ones, tumors with high productive TILs have a much better outcome than those with low productive TILs. And tumors with high viral predicted TILs have much worse outcome. You can think of this having a lot of bystander TILs that are sitting there taking up space. So this is an example of how we can take the work that's been shown here with the manifest and the TCR-seq and now trying to apply tools to make more sense of it. And what about questions that the study doesn't answer, but ongoing and future studies should be able to answer? Is neoadjuvant immunotherapy better than adjuvant immunotherapy? Yep. Are combinations of PD-1 inhibitors with chemo or with other IO agents better than just PD-1 inhibitors by themselves? And most importantly, if we can get an advance here, does it increase cure rates for patients? Now, why might neoadjuvant be better than adjuvant? Well, here I think you can take the example from Henry V at Agincourt. It's easier to inspire the troops when the enemy is in sight. Or an example that may be more familiar to some is Will Smith there looking at the aliens above the White House here. So having the enemy in sight certainly can help. And here we know that anti-tumor responses depend on the presence of antigen. The presence of antigen is going to certainly be the highest preoperatively, making the argument for neoadjuvant treatment. Now, does this actually hold up? Is neoadjuvant immunotherapy better than adjuvant? Well, here I'll point you to the abstract by Tina Casconi that's actually being presented today as a poster. And here she compared adjuvant immunotherapy, so the tumor is resected and then immunotherapy is given, versus neoadjuvant immunotherapy in the same mouse model. These are syngeneic models that have ovalbumin, so you can trace the T cells that are specifically reacting against the tumor. And PD-1 inhibition does prolong survival. In the neoadjuvant combination, immunotherapy is even better. And when you compare neoadjuvant versus adjuvant, here neoadjuvant is better at prolonging survival and reducing the frequency of lung metastases as well. So preclinically, this argues for neoadjuvant immunotherapy. And this isn't limited to lung cancer. I'll point out that there was an earlier publication in Cancer Discovery showing that neoadjuvant immunotherapy is superior to adjuvant immunotherapy for breast cancer. All right, so all this certainly generates excitement and a path forward for neoadjuvant immunotherapy. So what's actually happening? Well, as Dr. Pardal mentioned, there's a number of clinical studies that are definitively going to answer these key questions. Now, here's a randomized phase 2 study being conducted at MD Anderson of nivolumab, nivo plus ipi, or nivo plus chemo. And like earlier in the session, now you get the checkmates, the keynotes, and the empowers coming up. The checkmate is Checkmate 816. This is nivo ipi versus chemo versus nivo plus chemo. The keynote is platinum with pembro versus platinum doublet chemotherapy. And the Empower 30 is atezo plus chemo versus chemo. So between this set of studies, we really should have a definitive answer sooner rather than later about the efficacy of neoadjuvant therapy and the addition of immunotherapy. So what's the bottom line? Well, first of all, I'd like to congratulate the authors on what I think is really a very important proof of concept study. They show it's safe, it has impressive anti-tumor activity, and I think just as importantly, they show this innovative profiling approach for the MANA and the assessment of shared TCRs. To me, this foreshadows a future era with routine MANA profiling, matching up TCRs, and identification of productive TILs to better personalize and monitor immunotherapy. I think it also highlights major potential advantages for neoadjuvant as compared to adjuvant therapy, especially for immunotherapy when you've got that enemy in sight. It is important to standardize response criteria for immunotherapy and establish the surrogacy of major pathologic response. But I think it's also important to not wait for that before moving ahead. From today's session, imagine if we waited until PD-L1 assays were standardized before the phase 3s were launched. We wouldn't have sessions like we do today. Ongoing randomized trials are going to determine the efficacy of these approaches, and I think the rapid readout of activity facilitates innovation in this field, and you can see from the pace of this field from the earlier sessions, this is exactly what we need to make progress. Keep in mind, adjuvant studies, because of the endpoints, and you don't have tumor to examine, take 5 to 8 years to read out, and we need a faster pace of progress. So at the end of that, putting that all together, I think this step's an important step down the journey towards using immunotherapy for early stage lung cancer. And I think maybe it's time for us to stop saving our best therapies for last. With that, thank you for your attention.
Thank you, Dr. Haymack. And this closes now our clinical trial plenary session. I wanted to congratulate and thank all 5 of our abstract presenters, as well as our 5 discussants, who really made this, I think, one of the most exciting sessions at AACR this year. And thank you all for staying to the end. Have a good day.